Our guest of honor, Dr. Shalin Kumar, has arrived. So, welcome, sir. So, our guest of honor, Dr. Shalin Kumar, has arrived. So, welcome, sir. A flower to other faculty members who are here in this auditorium. Dr. Tulika Chandra, HOD of Transfusion Medicine. Dr. Rajiv Garg. Dr. Anup. A flower to other faculty members who are here in this auditorium. Dr. Rajiv Garg. Dr. Tulika Chandra, HOD of Transfusion Medicine. Dr. Rajiv Garg. Dr. Anup. Dr. Rajiv Garg. Dr. Rahat Hadi. Dr. Ajit Gandhi. Dr. Rohini Khurana. She is a speaker also here. Dr. Ajit Gandhi, the CME. Dr. Wahid. Dr. Rohini Khurana. She is a speaker also here today in the CME. Dr. Wahid. Dr. Tanmay. Dr. Kaleem. So you know what I am doing over here. Dr. Tanmay. Dr. Siddharth. So you know what I am doing over here. The oration of Dr. G.N. Agarwal we'll have just now. He's the son of Dr. G.N. Agarwal. The oration of Dr. G.N. Agarwal we'll have just now. Dr. Kamal Savlani. Dr. Kamal Savlani. And Dr. Harish. And Dr. Harish.
Vice Chancellor ma'am is en route and she'll be here in another 5 minutes, hopefully.
Good afternoon. The idea of radiating hope and blossoming care. With the idea of radiating hope and blossoming care, welcome to the 38th Foundation Day celebration of our Department of Radiation Oncology. We would first like to invite Professor Sonia on the stage, Professor Shalin Kumar sir, and Professor Manoj Kumar Gupta sir on the stage.
I would like to invite Professor Rajiv Gupta sir for the floral welcome of our prominent guests.
Now we would like to invite Professor N.K. Kanuni sir to give the welcome address.
Thank you, Aman. Good afternoon, ladies and gentlemen. Thank you, Aman. It is so wonderful to see you all here on this momentous day of Department of Radiation Oncology. Good afternoon, ladies and Foundation Day is an important occasion for all of us as we celebrate the achievements of the department. To see you all here on this came into existence on this day of in 1986, after the parent department of radiology was bifurcated into Department of Radiodiagnosis and Department of Radiotherapy. For all of us, hence 16 December is a very special day in the annals achievements of the Department of Radiation Oncology, and we are very fortunate on this day that Honorable Vice Chancellor, King George Medical University, Professor Sonia Nityanand, into Department of Radiodiagnosis and Department of Radiotherapy. Hence, 16 December is a very special day in the annals of the Department of Radiation Oncology, and we are very fortunate that Honorable Vice Chancellor, King George Medical University, Professor Sonia Nityanand, in spite of her very busy and hectic schedule for the days, she has very kindly accepted our invitation to grace the occasion as chief guest and bless us. Ma'am, your presence has elevated the significance of this occasion, and we are truly honored to have you here amongst us. On behalf of Department of Radiotherapy, Radiation Oncology, I am delighted to welcome you. I would also like to acknowledge the presence of our guest of honor, Professor Salim Kumar, Dean, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Professor Salim Kumar is a person of extraordinary vision, a beacon of knowledge, and a source of inspiration for all of us. Sir, your presence adds immense value to our event, and I deem it a great privilege to welcome you. I feel honored and privileged welcoming Professor G.N. Agrawal, Orator of the Year 2002-04, Professor M.K. Gupta, sir, Head of the Radiation Oncology, All India Institute of Medical Sciences, Rishikesh. Professor Gupta is a distinguished clinician and an academician par excellence, and he has stamped his authority in the field of radiation biology. Thank you, sir, for accepting our invitation to deliver 15th Professor G.N. Agrawal oration. A special welcome goes out to our distinguished speakers and chairpersons of the CME for the day, whose support to our cause have been nothing short of remarkable. It is gratifying to look around and see so many familiar faces sitting in the audience, especially Mrs. G.N. Agrawal, Mrs. M.C. Pant, Dr. Naseem Jamal, and many other faculty members of the KGMU and from SGPGI and RML IMS. Sir, your esteemed presence has indeed glorified the event and added a vibrancy to our humble gathering. Last but not the least, I extend warm welcome to all the members of the faculty from SGPGIMS, from RMLIMS, from KGMU, residents from KGMU, our students of Department of Radiation Oncology, workers of the Radiation Oncology, and all those who are present here. I give them a warm welcome. Thank you all for joining us. Thank you very much.
Thank you, sir, so much for your insightful words. Now I would like to call upon the stage our visionary leader and professor and head of department, Professor Rajiv Gupta, sir, for the annual report presentation.
Very good afternoon. On behalf of Department of Radiation Oncology, I welcome our chief guest, Honorable Vice Chancellor, Professor Sonia Nityanand ma'am, and our guest of honor, Professor Shalin Kumar sir. And I pay my tributes to my teachers, Professor G.N. Agrawal sir and Padam Shri late Professor M.C. Pant sir, and I welcome Madam G.N. Agrawal ma'am and ma'am Mrs. Pant. This will, okay. Achha. On this day of 16 December 86, we have traveled to 38 years since then, and in the honor of our founder head of department, Professor G.N. Agrawal sir, we are having prestigious Professor G.N. Agrawal oration in his name, and this is our 15th oration today. And this is our list of our past G.N. Agrawal orators, Professor G.N. Agrawal orators, which was done by many giants and stalwarts of radiation oncology, Professor G.K. Rath, Professor Shalin Kumar, Professor Shaili Ukku, Professor Shyam Kishore Srivastava, Ma'am Kamal Sani, Ma'am Professor Rajiv Sareen, and this is list. And today, Professor M.K. Gupta sir will give his oration. We are offering Cancer Awareness Day, World Cancer Day on the 4th February, and World No Tobacco Day on the 31st May. We got mobile cancer detection unit, and we do the camps at the remote villages and in the school. We organize the camps to educate people and detect malignancy in early stages. And we do the camps at the remote villages and in the school. We organize the camps and to educate people and detect malignancy in early stages. These are few acknowledgements. Thank you.
धन्यवाद सर। गत एक वर्ष में विभाग के कर्मचारियों और छात्रों द्वारा उत्कृष्ट प्रदर्शन किया है। आज मंच के माध्यम से विभागीय स्थापना दिवस पर हमें अवसर प्रदान हुआ है उन सभी को सम्मानित करने का। मैं सभी सम्मानित अतिथियों से अनुग्रह करता हूं कि कृपया मंच पर आगे आ जाएं। इस श्रृंखला में मैं आमंत्रित करता हूं श्री संदीप मिश्रा, प्रियंका शर्मा, एकता मौर्य, प्रियंका शर्मा, प्रियंका गौतम, एकता मौर्य, एकता मौर्य, प्रियंका गौतम, प्रियंका गौतम, प्रियंका गौतम टेक्नीशियन, एकता मौर्य, अवधेश कुमार यादव ओपीडी के कुशल संचालन के लिए, प्रियंका गौतम, अवधेश कुमार यादव ओपीडी संचालन के लिए, प्रियंका गौतम टेक्नीशियन, अवधेश कुमार यादव, अमित कुमार ओपीडी के कुशल संचालन के लिए, अवधेश कुमार यादव ओपीडी संचालन के लिए, शीबा फातिमा ब्रैकीथेरेपी के अमित कुमार संचालन के केयर के संचालन के लिए, हमें मोबाइल कैंसर डिटेक्शन यूनिट भारतीय इलेक्ट्रॉनिक लिमिटेड से प्राप्त हुई है। उसके संचालन में शीबा फातिमा ब्रैकीथेरेपी के कुशल संचालन के लिए अत्यधिक सहयोग प्राप्त हुआ है। इसके लिए पीओसीटी के जनरल मैनेजर हमें मोबाइल कैंसर डिटेक्शन यूनिट भारतीय इलेक्ट्रॉनिक लिमिटेड से प्राप्त हुई है। उसके संचालन में इस समय हमें पीओसीटी से अत्यधिक सहयोग प्राप्त हुआ है। इसके लिए पीओसीटी के जनरल मैनेजर अमित अग्रवाल जी, हमारे जो विद्यार्थी हैं बीएससी रेडियोथेरेपी के लिए ओमल वाजपेयी, हम विद्यार्थी हैं बीएससी रेडियोथेरेपी के लिए ओमल वाजपेयी, डिप्लोमा रेडियोथेरेपी के लिए आस्था शर्मा। निर्मल और राजेंद्र मौर्य जी यहाँ पर अभी पीओसीटी के संचालन के लिए, निर्मल और राजेंद्र मौर्य जी का मोबाइल कैंसर डिटेक्शन यूनिट के संचालन के लिए पीओसीटी के संचालन के लिए हुआ राजेंद्र कुमार मौर्य का मोबाइल कैंसर डिटेक्शन यूनिट के संचालन के लिए बहुत जगह हमारे सहयोग प्राप्त हुआ राजेंद्र कुमार मौर्य। इन्होंने बहुत जगह हमारे कैंप लगाने में मदद की निर्मल कुमार ने, और इनका सहयोग दिया है निर्मल कुमार ने। आप सभी का विभाग के सहयोग के लिए हार्दिक अभिनंदन, नमन। आप सभी का विभाग के सहयोग के लिए हार्दिक अभिनंदन, नमन।
As we move forward, we now like to call upon the stage Professor Shaleen Kumar sir for an address by the guest of honor.
And now, now in her present capacity as an institution builder and much more. It's a pleasure to share the stage with her. Professor Manoj Gupta, a senior colleague who has been 2 years my senior in training at KGMC. Senior professors, colleagues in front, and I cannot forget Professor Jean Agarwal, and now represented by Madam Agarwal, and Professor MC Pant, now represented by Mrs. Nirmala Pant. So, मैं हिंदी में बात करने की अनुमति चाहूँगा मैडम जी। देखिए 1986 में विभाग अलग हुए और रेडियोथेरेपी की स्थापना हुई, अलग से एक आइडेंटिटी, रेडिएशन ऑनकोलॉजी, तब रेडियोथेरेपी कहते थे हम लोग। इसमें बहुत लोगों ने, मैं यहाँ 89 में आया, मेरी ऐसी यादें जुड़ी हुई हैं इस जगह से जिसके बारे में मैं कुछ कहना चाहूँगा आज। Normally I'm a formal guy, but today I'd like to say something from my heart. जी.एन. अग्रवाल साहब का जो पर्सनालिटी थी उसको मैं कहूँगा a simple person, a humble person, very supportive, very forgiving, happy-go-lucky and pleasantly forgetful. बड़ी अच्छी बात है, भूल जाते हैं सर। This is, you know, he was so forgetful कि he would not carry any sort of regrets in his life, something to learn. He was complimented by MC Pant Sahab. I'm going back 30 years. Dynamic, energetic, proactive, nothing is impossible in his dictionary. Nothing is impossible. फिर मधु श्रीवास्तव और माली साहब भी थे और फिर हमारे यहाँ एक सीटी स्कैनर लगा हुआ था और उसमें पीके श्रीवास्तव साहब, सुनील कुमार साहब और जमाल साहब, इनकी हंसी ही गूंजती रहती थी वहाँ पर हर समय। हंसी ही नहीं खत्म होती थी। जैसे ही आप प्रवेश करें अंदर तो वहाँ हंसना। मैं ऐसे माहौल में पड़ा हूँ यहाँ पर। और इनके साथ थे हमारे एक टेक्नीशियन साहब थे विनोद, वो सुपर एनवेट हो चुके हैं, उनका बेटा अब काम करता है मेरे ख्याल से कैंसर इंस्टीट्यूट में। निगम साहब थे और श्रीवास्तव साहब थे। गुलशन राय साहब थे हमारे फिजिसिस्ट और वो क्वाइट पर्सन। और इस जगह के में उस समय एक मशीन पड़ी हुई थी क्रेट में, कोबाल्ट यूनिट। मेरी आधी एमडी खत्म हो गई थी, उनका बेटा और फिर वो काम करता है मेरे ख्याल से कैंसर इंस्टीट्यूट में। तो हमें निगम साहब थे और श्रीवास्तव साहब थे, हम ही फिजिक्स का काम करें, राय साहब थे हमारे टेक्नीशियन का काम करें, हम ही डॉक्टर का काम करें, और इस जगह के में उस समय एक मशीन पड़ी हुई थी क्रेट में, कोबाल्ट यूनिट। मेरी आधी एमडी खत्म हो गई थी और फिर वो क्रेट काम करें और कीमोथेरेपी। तो हमें वो अपॉर्चुनिटी मिली कि हम ही फिजिक्स का काम करें, हम ही टेक्नीशियन का काम करें, हम ही डॉक्टर का काम करें, वो फ्रीडम, ओपीडी भी देखें जिसमें कि 2 बजे खाली भी हो जाए, कुछ भी करें, सीखें, समझें, खुद समझें, और फिर वार्ड्स का भी काम करें, और प्रोटेक्शन, आई वुड से, वो ट्रेनिंग टीचर्स, दैट हैज बीन, वो ट्रेनिंग सो क्रूशियल एंड अपॉर्चुनिटी, वो ऑन रिफ्लेक्शन, दैट इट हैज, कि आप उसके कुछ भी करें, सीखें, समझें, खुद समझें, सब कहीं ना कहीं वॉचफुल प्रोटेक्शन, आई वुड से, of the teachers, I can only say that has been so crucial and formative.
Thank you.
On reflection, that it has, उसके बाद से जितने लोग KGMC से निकले हैं, सब कहीं ना कहीं कुछ ना कुछ तो कर ही रहे हैं. To this, I can only say, this department, the people here, how they have crafted us, formatted us. It is a lifetime. It is a lifetime of gratitude. These are memories. This institution, this department, and the people here, I also had how they have crafted us, formatted us, good, bad, indifferent. They were also. These are memories. They also cannot forget. So with these words, I think I would like to seniors, Professor M.K. Gupta, by just sharing how happy I am. They also did Dept. To be back here. So with these words, I think I would like to memories and emotions this place evokes for me personally. Thank you. Thank you.
Thank you, sir, for your inspiring words.
To express our gratitude to the dignitaries for gracing this occasion, I request Professor Rajendra Kumar, sir, I request Professor Rajendra Kumar, sir, to felicitate our Chief Guest of Honor, Professor Sonia Nityanand, ma'am. Thank you, ma'am, for gracing the event with your presence. And for your unwavering support to our department.
Now we request Dr. Mrinalini Verma, ma'am, to felicitate Professor Shaleen Kumar, sir. Sir, it is an absolute privilege to have you with us as we celebrate this milestone.
Now inviting Professor Tirthraj Verma, sir, to honor Professor M.K. Gupta, sir. Thank you, sir, for your remarkable contributions to education, research, and patient care, and always inspiring us to push our boundaries.
Now it is our privilege to welcome our revered Vice Chancellor, ma'am, Professor Sonia Nityanand, ma'am, whose visionary leadership has been instrumental in shaping our medical university into a beacon of knowledge. We are honored by your presence and look forward to your inspiring words.
Professor Shaleen Kumar, who's the head of the Department of Radiotherapy at Sanjay Gandhi Postgraduate Institute of Medical Sciences, and the Dean and the guest of honor for today, Professor Mahesh. He is going to give the oration today. And Dr. Rajiv, head of the department, Dr. Sudhir Singh, all the other esteemed faculty members of the Department of Radiotherapy, Mrs. Agarwal, Mrs. Pant, I can see Dr. Madhup Rastogi, and all the staff of the department. Congratulations to all of you on this 38th Foundation Day. So 38 years of a glorious progress of the Department of Radiotherapy, very nicely brought out by Dr. Shaleen Kumar. By the way, Dr. Mahesh and Dr. Neeraj Rastogi, I just learned, were the first MD students of this department. So Dr. Manoj Gupta, Dr. Rastogi from the Department of Radiotherapy at Sanjay Gandhi PGI were the first MD students. And no better person than Dr. Manoj for coming and giving this oration. I am actually very, very happy that he has come, because for people who don't know, he is my batchmate. We both studied together in MBBS. And I always tell to the new MBBS students who come and join that the bonds that one forms during MBBS years cannot be compared to any other kind of friendship. So that's the kind of bond I share with Professor Gupta, who's now, of course, a professor and head Department of Radiation Oncology at the AIIMS Rishikesh. I think those bonds will continue, and I'm so delighted to have you, Professor Shaleen also, it's so good to have two people on my two sides who've been very deeply associated with me. Dr. Shaleen has been all through at SGPedia, and so I have been. And we've been very closely associated both as colleagues and as Georgians. As he brought out, he's done his MBBS and MD from the King George's Medical College, and so have I. So we've had that bond of being Georgians, and we've also, since I also deal with cancer patients, with blood cancer patients, and I'm heavily dependent on the Department of Radiotherapy, we've had very close association. So thank you, Dr. Shaleen, for being there. This is a department with a lot of flagship programs. And as you heard the head of the department bringing out that there is a unit of there is a palliative care facility, there is home care and hospice care, which is very active in this department. And I think these are very two important flagship programs. And congratulations to the head that he has brought them into place and is running them successfully. Last year, or rather I would say 24, we are at the end of it. This year only, we got through the CSR funds a mobile cancer van. And in a very short period of time, the department has made a program around it, and it has visited many districts, and the data was highlighted by you. And I hope in the year to come, it also gets equipped with a digital mammography machine. Let's strive for that. This year, since there has been a significant hike in the budget, equipment budget for the for KGMU from 50 crores to 300 crores. So one of the departments which has got again a very good and generous funding is Department of Radiotherapy, and it will get a high energy linear accelerator very soon, so that the waiting list of the patients becomes less. Lately, the department has joined hands with me in my mission against cervical cancer, and especially the cervical cancer vaccination program. And Dr. Sudhir and his team, along with the head of the department, helped in carrying out the cervical cancer vaccination free of cost, which was in the convocation function of the Kanpur University. And I hope this mission continues and this grows forward. Nothing like preventive medicine, preventive cancer. I want the department, we've heard the beautiful history of the department, how each head of the department has contributed to the growth and development. And in the last 1 year, aap log ne is department ko grow karaya hai. That's why we could hear a very progressive and good report of the department for last 1 year. So आप लोग सबको जितना staff यहाँ आया है, Foundation Day आप लोग का, it's a day to celebrate your achievements, your contributions. Big congratulations to all the staff here, and especially to those जिनको आज honor करा गया है, जिनको certificates दिए गए हैं. That you stood out from the rest and got these certificates, and Hope you keep up your dedicated performance, because ultimately it translates into your performance for patient care, which is the mission of any medical institute. So congratulations again, the department. Hope you achieve even greater heights in the year to come. And again, I thank the guest of honor, Dr. Shalin Kumar, to grace this occasion, and my batchmate, Dr. Gupta, to come and give the oration today. And he's a very, very hardworking and a very, I would say he was a very intelligent batchmate of ours, and he's risen to a very high position. And fond remembrances to Dr. Agarwal, Dr. G.N. Agarwal, and Dr. Pant. Thank you very much, and good wishes. Jai Hind.
Thank you, ma'am, for your inspiring words, which have set the tone for our celebrations today. Now, it is our pleasure to invite Professor Seema Gupta, ma'am, to present the citations for our distinguished orator, Professor Manoj Gupta, sir.
Good afternoon and thank you. Today here in 38th Foundation Day celebration of Radiation Oncology Department, I express my sincere gratitude and regards to our chief guest, Honorable Vice Chancellor Professor Sonia Nityanand ma'am, and warm regards to all revered faculty members of our and other medical institutions. Now in this occasion, we are very fortunate and privileged to have with us our distinguished guest faculty, Professor Manoj Gupta, sir, ex-Dean, Head of Department Radiation Oncology, AIIMS Rishikesh, to deliver Professor G.N. Lal oration. So kindly accept our greetings, sir. Professor Manoj Gupta has been credited with several national and international prestigious awards, including Nargis Dutt Memorial International Fellowship, UICC Fellowship, American Cancer Society Scholarship, European Cancer Society Education Award, AROI International Fellowship. He has delivered many lectures and prestigious orations, including Professor B.N. Lal oration, Dr. B.D. Gupta oration. He has published a number of publications in several esteemed journals. He has been into leadership role. He has been playing leadership role in Association of Radiation Oncologists of India since 2018, and still he is into it. His area of interest has been head and neck cancer, breast cancer, and clinical radiobiology, with special focus on teaching and quality training of PG students in radiation oncology, and correspondingly, he has been conducting teaching courses in the clinical radiobiology in India for PG students of radiation oncology. So with these words, I very humbly invite Professor Manoj Gupta, sir, for the oration. And here is Dr. G.N. Lal Memorial Oration, be it known that Dr. M.K. Gupta, Professor and Head Radiation Oncology, All India Institute of Medical Sciences, Rishikesh, Uttarakhand, has been awarded Dr. G.N. Lal Oration for the year 2024 in recognition of his valuable contribution in the field of oncology. Dr. M.K. Gupta has delivered oration, Cancer Care in Country Closing the Care Gap, at the 38th Foundation Day celebration on 16 December 2024 at KG Medical University, UP, Lucknow. Thank you.
this year the theme of the World Cancer Day was close the care gap. So I thought that let me speak my thoughts on how we can close the care gap which is there in our country. And these thoughts are basically the observation of my 35 years of clinical practice in public sector hospitals. So I'm just will share these thoughts with all of you. But before that, let us look at the problem. What is the basic problem? Now, if you look at the Indian scenario, 15 lakhs new cancer cases are detected every year, and out of 15 lakhs, 9 lakhs cancer patients die. Anytime we do have 45 lakhs cancer cases in our country. If you look at the incidence, there is a huge geographical variation across the globe. The incidence in our country is around 110 per 100,000. But if you compare with Europe, it is 300 per 100,000, and in US, it is 450 per 100,000. USA, no doubt, has incidence 4 times higher than India, but remember that India has 4 times more population than USA. So if you look at the absolute number of cancer cases detected every year, I think we have the same number detected every year. We all know that incidence is increasing because of the following factor: lifestyle. We people are more fascinated to Western lifestyle. Tobacco and alcohol consumption, we all know that more and more people falling prey to tobacco and alcohol consumption. Air pollution, now this is a very hot topic, especially during the winter, and we know that air quality is so bad in most of the metro cities, and Delhi it is the worst. And it is said that if you are staying in the Delhi, even if you are non-smoker, you smoke almost 50 cigarettes per day because of this pollution. Food habits, again, we all are shifting from our conventional home-cooked food to ready-to-eat foods. Then adulterated foods, we know that preservatives are being used, so frequently that even milk, which we get, the packet milk, there are preservatives in that, milk. Then, of course, the average age is increasing. If you look at the average age at the time of independence, I think it was just 35 years, but now it has gone up to 70 years. Now, if you look at the demography by age group, from 1960 onward, continuously there is an increase in the population with the age 60 years and above. And if you look at the percentage of people with more than 40 years of age, as of today, it is around 35%. But if you look at the projected population at 2050, you will appreciate that projected population is around 50% of the population will be more than 40 years of age, and that is the age which is most vulnerable for cancer and when cancer starts peaking up. So no wonder that by 2050, we see an epidemic of cancers in our country. So in future, the most important factor for higher incidence of cancer will be the higher older population. Now, if you look at the available infrastructure in the country, especially in radiotherapy treatment facilities, we know that we have a 1400 million population, and as per WHO criteria, we should have 1 teletherapy machines per million population. Ideally, it should be 4. It has been set 4 per million for the developed countries, but at least minimum 1 teletherapy machine for developing countries per million population we should have. And as per this minimum criteria, we should have around 1400 teletherapy machines. How many we do have? 700. And remember that approximately 250 are in government hospitals, just 250, less than 50%. So there is a huge difference between demand and supplies. This is around 700 as of today. Every year, 60 new machines are added. But remember that every year we add 20 million population, so 20 out of 60, 20 machines just used to counter this increased burden of population. Out of 60, 20 machines just replace the older version. So net addition is just 20 machines per year. And by this calculation, it will take 40 years to bridge the gap, which is a pretty long time. Now let me change the gear. If you look at the average income in our country, around 65% of the population earn between less than 10,000 to 40,000 rupees per month. 65% of the population. And this population mainly depend upon government hospitals for health care. So out of 1400 million population, 65%, 900 million population depends on upon the government hospital for cancer care treatment. We do have just 250 machines in the government hospitals, so there is a deficit of around 650 machines. If you look at the job demography, only less than 10% of the people are employed in a government sector or in private organized sector. Otherwise, around 90% of them, depend either on agriculture income, or they are employed in unorganized sector, or they are unemployed, or they are part-time daily wagers. So just to summarize all these logistic issues, there is a huge gap between demand and supply of radiotherapy facilities. 65% of the population depends on government hospitals for treatment. 90% of the population work in unorganized sector, including agriculture. Now, with this background, I would like to tell you a story. Now, there is a person, Sohan, who lives happily in town Bareilly with his wife and 2 kids. He works in a shop. His salary is 20,000 per month. One fine morning, he just detects a swelling in the neck. He just goes to district hospital, where he was diagnosed as suspected neck malignancy, and he was referred to cancer hospital or to higher center. Because he belongs to a group who depends upon the government hospital for any health care. So he looks in Bareilly, any cancer hospital. He found no, Bareilly there is no hospital which provides the cancer treatment. So he looks to the adjacent district, Shahjahanpur, there is no facility. Again, adjacent district, Hardoi, there is no facility. And the nearest facility available is in Lucknow. And Lucknow is at a distance of around 250 kilometers from Bareilly, and it takes around 5 hours to come to Lucknow. So anyway, he traveled to Lucknow. He just goes to one of the very reputed hospital of Lucknow. A big disclaimer, this picture is of King George Medical University, but this story has no relationship with this medical college. This is just a reflection of any state medical college. So when he goes to this hospital, it took 3 days for routine investigation and reports. He was given a CT scan date because there is a long waiting list. He doesn't want to waste his time, so he got the CT scan done from private hospital, which involves out-of-pocket expenses. After CT scan, biopsy was done, and he was advised to come after 1 week for the histopathology report. After 1 week, he was diagnosed with carcinoma oropharynx, stage T3 and 2AM0, referred to radiation oncology department, re-examined and given radiation date. Again, there is a long waiting list, so he was given a radiation date. But at the same time, symptomatic treatment was given, and since the long waiting period, so he was started on neoadjuvant chemotherapy, given first cycle of chemotherapy and advised to come after 3 weeks for second cycle. So he went back to home, but at home on 9th day, patient developed high-grade fever. Again, he rushed to Lucknow, traveling almost 250 kilometers. He was admitted and diagnosed as neutropenic fever, managed and discharged after 5 days, and he was advised to come for second cycle of chemotherapy. At 21st day, he went to Lucknow again, took second cycle with reduced dose of chemotherapy now in view of neutropenic fever, and he was asked to come after 3 weeks for radiotherapy scan for IMRT. So on 42nd day, radiotherapy planning scan was done and advised to come after 7 days for starting radiation, because that is the normal time in any government institution for preparing a plan for IMRT. So on 49th day, he again goes back to Lucknow, and radiation started on OPD basis for 7 weeks with weekly cisplatin injection, and he was asked to make arrangement for his stay because most of the state medical college radiotherapy department has very limited number of beds. So again, out of pocket expenses. He was fortunate that the whole treatment went uneventful and treatment was completed and he was discharged with advice to come for review after 6 weeks. So 98th day, the treatment was completed. So it took almost 100 days from diagnosis from diagnosis to treatment. So it's a pretty long, prolonged treatment. So what could be the logistic side effect of this treatment, of this prolonged treatment? R706. Total districts in our country are around 780. And now Honorable Prime Minister, has a plan to have one medical college in each district. And with 706 medical colleges as of today, I think we are very near to achieve this goal. Out of 706, 386 are government medical colleges, 320 private medical colleges. Approximately 35% are providing radiation treatment facilities. So total number of medical colleges with radiation treatment facilities are just 250. Cannot force state to have radiotherapy facility in every medical college. So what is
Center is very simple. Center cannot force, but center can force through one of the agencies, and that is through National Medical Commission. So through National Medical Commission, if it can be made mandatory for every medical college to have a radiotherapy facility, then suddenly you will have 450 machines. So already existing 700. So suddenly the number will jump from 700 to 1150, which is very near to the target. If you look at the manpower in the rural radiation department, this is the ideal manpower, but naturally again it takes time to have an ideal manpower and it involves a lot of expenditure. So the solution is that first step should be to employ at least one faculty in radiation oncology and to start a radiation wing. So that is the first step which government can do, that start a cancer wing, appoint a radiation oncologist. Even if there is no machine, how this radiation oncology will help to the cancer patient?
Number one, early detection. So he will detect the case at an early stage. He will do all the diagnostic workup and staging of the disease and planning of the treatment. And suppose the treatment plan involves chemotherapy. So the chemotherapy can be administered at the door of the patient. And this will avoid multiple visits to cancer center which is far away, if we have cancer treatment facility in every district. Then he can, provide the follow-up of these cancer patient. Again, multiple visit can be avoided to the distant cancer center. He can, also provide the palliative treatment, again at the door of patient. So this will again avoid the multiple visit to the cancer center. End-of-life care, including hospice facility, pain management, including morphine disbursement, cancer registry. Now, we have cancer registries in our country in pockets, which just cover around 15% of our population. Just imagine that if every district have a cancer registry, we can cover most of our population. And certainly when radiation oncologist is appointed there, he will make effort to procure the equipment as well. Now, regarding the equipment, minimum infrastructure required for radiotherapy department are linear accelerator, CT simulator, and brachytherapy, but these are very expensive equipment, and it requires around 30 crores to procure all these three basic facilities. So question is there any way by which we can cut down the cost from 30 crore? Answer is yes. Now the answer comes, if you look at the spectrum of the disease, we in our country, we see most common cancers, lung, breast, cervix, and head and neck. At the same time, thank you, Dr. Sonia. I know you are too busy, so thank you very much. Yeah, thank you very much. Yeah, sure, please. Thank you very much. So if you look at the most common cancer which we see in our country, the most common cancers are lung, breast, cervix, head and neck. So the most common cancer in our countries are lung, breast, cervix, head and neck. If you look at the stage at which they present, they usually present in locally advanced stage. So just remember that most common cancer, and majority of them, almost 2/3 of them, present in a very advanced stage or locally advanced stage. Now this is the subset of the patients which usually come in our OPD for treatment, and these patients, remember, they don't require any high-tech treatment like IMRT, IGRT, VMAT, SRS, or SBRT. Now, these cancers can be managed very effectively just by 3D conformal radiotherapy and maximum with simple IMRT with 2D verification. That's it. So, LINAC with technology of 3D CRT and IMRT with 2D image verification is good enough for treatment of majority of cancer which we see in our country. And this will cut down the cost drastically by more than 50%. So LINAC cost 20 crores will come down to 10 crores. CT simulator, we know the diagnostic CT scan is available in every medical college with some accessories like flat couch top and wall lasers. It can be used for simulation for majority of the treatment site. And cases which needs large bore CT scan, there will be few cases which require large bore CT scan, that can be referred to center where CT simulation facility is available. And this will just involve one visit to that center, and then these images can be transferred to the treatment center. Now, so for this purpose, one CT simulator can be shared by 3-4 medical college. And remember, when we have medical college in every district, so we need not to have CT simulator in every district medical college, but it can be shared by 3-4 medical college, and it will reduce the cost drastically. Brachytherapy, most common cancer we know treated with brachytherapy is carcinoma cervix. So again, brachytherapy machine can be shared by 3-4 district medical college, not required that every medical college should have brachytherapy machine. It will just require 2 to 3 visits by the patient, and again it will cut down the cost. Bulk purchase, if companies are assured, for example, say 50 to 100 machines will be procured by government every year, then again it will bring down the cost. Custom duty, now these radiotherapy equipment should be categorized as life-saving equipment, and the custom duty should be exempted, which is very high as of now. It is around 20% for government setup and more than 20% for private setup. So to summarize the cost cutting, we should have low-tech linear accelerator, diagnostic CT scan to be used for simulation, CT simulator for specific cases to be shared between 3 to 4 medical colleges, brachytherapy machine also to be shared between 3 to 4 medical colleges, dosimeter equipment to be shared between medical colleges again. Every medical college need not to buy these dosimetric instruments. Bulk purchase, make in India should be encouraged, but word of caution that the quality should not be compromised. They should have same quality as their counterpart from abroad. Custom duty to be exempted as it's a life-saving medical equipment and it will cut down the cost drastically, no doubt. And refurbished machines should be allowed. So these are the various cost-cutting, measures which can be taken. Now coming on to the role of AIMS. Now right now we do have 23 AIMS, and the plan is that one AIM should be there in every district. So AIMS and these state medical colleges should work like hub and spoke model. So AIMS will be hub, and all medical college radiotherapy department will be spokes. And AIMS should be funded liberally so that AIMS should have all the modern radiotherapy facility like IGRT, 4DRT, ischiotactic radiosurgery, SBRT, VMAT, interstitial brachytherapy, blah, 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 everything they should have. So all patients who require these high-tech treatment, they should be referred from state medical college to AIMS. Rest, all the patients should be treated at the district medical college, and the treatment should be provided at the doorstep of the patient. So ladies and gentlemen, these were some thoughts which came to my mind, and I thought that I would like to share these thoughts on this oration. So just to summarize how we can fill up this gap which is there in our country, one is that it should be made mandatory to have cancer wing in every medical college. It should be made mandatory to have radiotherapy facility in every medical college so that we can provide the treatment to the doorstep of the patient. Linear accelerator with just 3D conformal radiotherapy facility and intensity modulated radiotherapy with 2D imaging is sufficient to treat majority of the patients. Sharing CT simulator between 3 to 4 adjacent medical colleges. Sharing brachytherapy between 3 to 4 adjacent medical college. Sharing physics equipment. We should work on a model like hub and spoke, and AIM should be working as hub, and all the state medical should be working as spoke, and hub should have all the modern radiotherapy facilities which is there in the world. So with these words, I conclude, and once again I pay my tribute to this great man. My Shat Shat Pranam to my guru and mentor. Thank you very much.
Thank you, sir, for this thought-provoking oration. I would say that you navigated through this topic in a very nuanced and statistical manner and really raised our awareness regarding this problem in our society. Thank you, sir. So now, as we come to a conclusion to our department's Foundation Day, please join me in welcoming Professor Kirti Srivastava ma'am to express the gratitude to our esteemed guests and dignitaries and propose the vote of thanks.
Thank you, Aman. So I can see the restlessness in the auditorium now. It's too late. On behalf of the Department of Radiation Oncology, I would like to extend my heartfelt gratitude to our esteemed chief guest, Vice Chancellor Professor Sonia Nityanand ma'am, our guest of honor, Professor Shaleen Kumar, a renowned radiation oncologist and Dean, SGPGIMS Lucknow. Speaker for today's oration, Professor M.K. Gupta sir, whose oration we have just heard, which was excellent. Your thoughts of wisdom have truly inspired us, sir. I also would like to extend my sincere thanks to all the head of the departments and senior faculty members from various institutes, Dr. Madhu Prastogi, Dr. Rajiv Pant, Dr. Sharad, Dr. Neeraj Rastogi sir, and special thanks to Nirmala Pant ma'am and Mrs. Jane Agarwal ma'am for sparing time and coming here to encourage us. I also would like to extend my sincere thanks to those who are involved in organizing this function, our students and faculty members, and special thanks to Mr. Danish and Professor Sudhir, who is there for, always there, and for their consistent support, because without him we cannot even think of organizing this function. I also thank the speakers for the CME, which now will take place, Dr. Rohini Khurana and Dr. Puneet. I think he is also here. With this, we come to the conclusion of this Foundation Day celebration. Thank you very much. सर आपने बहुत अच्छे टॉपिक, मतलब मैं बहुत टाइम से इस पे इतनी कोशिश कर रही हूँ करने की, वो पहुँच पाते हैं। अमन सर का वो वहाँ पहुँचाना है, मनोज गुप्ता सर का, कहाँ उनको पूछो कहाँ देना है।
Thank you, everyone. I would request everyone to join us for high tea, following which we will have our CME. ये है मैम फर्स्ट है ना प्रेजेंटेशन आप कितनी स्लाइड्स हैं 34 स्लाइड्स मैम ठीक देखो लास्ट स्लाइड थैंक यू है ठीक है यस मैम ठीक अच्छा मैं इसको सेव ही कर देती हूँ फिर इसमें ठीक
Very good afternoon. On behalf of the
पुनीत सर का है, पता है आपको कौन सा वाला है? सर शुरू कर। ये पुनीत सर का है? नहीं, ये तो शगुन मैम का है।
सर पुनीत सर का दिखा रहा हूँ एक मिनट।
उनका ये करंट स्टेट ऑफ सर्जिकल मैनेजमेंट ऑफ वो है।
सर पुनीत सर का ये है।
पक्का? नहीं भाई।
ये।
हाँ हाँ हाँ, ठीक है ठीक है। So, good afternoon and a warm welcome to our distinguished guests, esteemed faculty members, delegates to our CME program on breast cancer. Here we aim to share knowledge, expertise, and best practices in the fight for this formidable disease. We are honored by your presence and look forward to an afternoon of enlightening discussions and learnings. Now, without much further ado, we would like to invite upon the stage our distinguished chairpersons for the first session, Professor Kirti Shrivastava ma'am and Professor Rajiv Pant sir.
For the first session, we would like to invite Dr. Puneet Prakash. He is Associate Professor, Department of Surgical Oncology. He was MS General Surgery from University of Medical Sciences, New Delhi, and MCH Surgical Oncology from King George's Medical College. So axillary management is very important nowadays because gradually we are reducing the dose of axilla, avoiding axilla. So axillary clearance a matter of prime importance. So I would like Dr. Puneet Prakash to throw some light on the axillary clearance or axillary management. Dr. Puneet.
Thank you, sir. Respected chairpersons, senior faculty members from KGMU, SGPGI, SSCI, RML Institute. At the outset, I would like to congratulate Department of Radiation Oncology, King George's Medical University on its 38th birthday. And would like to thank Professor Rajiv Gupta sir, Sudhir sir for inviting me to give a talk on current status of surgical management of axilla in cancer of the breast. Yeah. Thank you. So while we are discussing the current status of surgical management of axilla in cancer breast, my roadmap will be, why do we need surgery for axillary lymph nodes in cancer breast? I mean, the disease is in the breast, so why do we need to address axilla at all? Second is, why do we need a de-escalation of surgery in the cancer breast? Everybody is talking about organ preservation and de-escalation of the surgery. What is sentinel lymph node biopsy? And whether is it equal or better than axillary lymph node dissection? And last but not the least, is axillary radiotherapy better than surgery? So before we go ahead, let's revise a bit of anatomy from our MBBS days. This is the area of the cancer, this is the area of the breast, and these are the draining lymph nodes which lie along the axillary vein. So they are divided into 3 groups, level 1, 2, and 3. So level 1 is on the lateral aspect of the pectoralis minor muscle, level 2 is deep to pec minor, and level 3 is medial to pec minor muscles. Now, when I will be discussing about the management of axilla, I will be using few terms like clinically N0, pathologically N0. They are divided into 3 groups, level 1, 2, and 3. So how we decide, how do we decide whether the node is clinically N0 or not? Level 2 is deep to pec minor. There are various modes of examination, the preoperative assessment of axilla, clinical examination. I will be discussing about the management of axilla. I will be using few terms like clinically N0, along with pathologically N0, mammography, CT, and so how we decide? How do we decide the important point the node is clinically N0 or not? There are various modes of axilla along with the fine operative assessment of cytology, clinical examination of high resolution ultrasound and specificity of 100%. Resolution ultrasound of the axilla along with FNAC. Mammography, relying on ultrasound of the axilla and FNAC a lot. The important point to be highlighted here is that then the second question was, why do we need surgery for axilla in cancer cytology? As we can see here, close to 80% and a specificity of 100%. As the size of the tumor increases, on the chances of the axilla and FNAC node metastasis to axillary lymph node increases. Then the second question was, why do we need surgery for axilla in cancer breast? Of the tumor, as we can see chances in this table, 15 to 20% of the chances. As the size of the tumor increases, the chances of lymph node metastasis. So now coming to surgical staging of axilla, why do we do it? The nodal status determines 5 cm of the tumor, and therefore it predicts outcome. 15 to 20% of nodal status influences the adjuvant therapy. Though in the current situation, now coming to surgical staging of axilla, why do we do it? The nodal status now we are moving ahead to, and therefore it predicts outcome. Molecular subtypes. Nodal status influences the adjuvant therapy. Does influence, but not in the current situation. And axillary lymph node has clearance. Its relevance because now we are moving. ALND provides an excellent long-term control. It's a treatment. So nodal status does influence, but not to that extent. And axillary lymph node, 1.4% of the patients who were treated with NSCP-BP04 trial with MRM had only 1.4% of the patients had axillary recurrences in a 10-year follow-up. But the important thing is that can staging of axilla be done through selective removal of lymph nodes? This brings me to the concept of sentinel lymph nodes. Sentinel is nothing else but the first responder of the police. The first draining lymph node. We can name it in another terms like blue node if you're using a blue dye. If you're using a radioactive isotope, then it is known as the hottest node, or any suspicious palpable node, or a node to which the blue lymphatics track. These are the first lymph nodes, and they have the maximum chances that the tumor will be localized to such nodes. If we can target them, then we can de-escalate the surgery for axilla. As with the understanding of any scientific discovery, just as our understanding of gravity has evolved, this is Galileo Galilei, and he initially described about what he thought about gravity was that all objects experience same gravitational force. Then came Sir Isaac Newton, who defined gravity as a force between two objects with masses. And finally, this person, the great Albert Einstein, redefined our idea of gravity by saying that actually it is the bends in the fabric of space and time due to the presence of large masses. Similarly, evolution of breast surgery, the great de-escalation has progressed over the last maybe 50 to 60 years. This was Professor William Halstead, and his initial theory was that the cancer spreads in an orderly fashion involving the lymph nodes first, and subsequently it involves the blood vessels. The paradigm shift was when Professor Bernard Fisher suggested that breast cancer is a systemic disease and it does not spread in an orderly fashion. So no matter how much loco-regional treatment we do, the improvement will only it will not show a substantial improvement if we do not incorporate other treatment modalities. And finally, Professor Armando Giuliano, who championed the cause of sentinel lymph node biopsy, saying that one size does not fit all, and axillary lymph node dissection is not necessary for every patient. So continuing with this, the paradigm shift from axillary lymph node dissection was in NSABP B04 trial, which was launched by Professor Fisher, and it showed that radical mastectomy was no longer required and less aggressive surgery, avoiding radical mastectomy, had similar outcomes as compared to total mastectomy or total mastectomy plus adjuvant radiation. Professor Fisher further moved ahead with NSABP B06 trial, in which he suggested that not even removing the entire breast, if we remove the tumor with negative margins and do a formal axillary lymph node clearance, then followed by radiation therapy, then the patients may have similar outcomes as compared to MRM. This was a 25 years of follow-up of NSABP B06 trial, and it showed that breast irradiation continues to be appropriate therapy for women with breast cancer, provided that the margins of the resected specimen are free of tumor and acceptable cosmetic results are obtained. Now, why we are talking about sentinel lymph node biopsy? Because these are the pictures we see in our OPD very often. But sentinel lymph node biopsy has eliminated the need for axillary dissection in patients whose sentinel lymph node is tumor-free, and axillary management in clinically N0 axilla receiving upfront surgery. Now coming to specific subset of patient in which they are clinically N0, they don't have any palpable nodes, the ultrasound of the axilla is not suggestive of any significant lymphadenopathy, and these patients undergo sentinel lymph node biopsy, which turn out to be negative. These are the major landmark trials, the NSABP B32, the Almanac, and the Milan trial, which has suggested that there was no difference in disease-free survival or overall survival between sentinel lymph node biopsy alone or axillary lymph node dissection. Moving ahead, suppose if you have done a sentinel lymph node biopsy and it turns out to be positive in a patient in whom there was no sign of clinically positive axillary lymph nodes, then what do we have? This was the landmark trial Z11 by Fisher, because everybody talks about Z11. So let's discuss Z11 in a bit more detail. This was a trial which recruited patients between 1999 to 2004, and it included early breast cancer patients who were randomized after doing a sentinel lymph node biopsy. Two groups, whether one group was to undergo axillary lymph node clearance, and the other group was after sentinel lymph node biopsy, only observation was done. Here the point I want to highlight is that the patients who underwent axillary lymph node clearance after a formal sentinel lymph node biopsy, additional 13% to 27% of the patients had pathologically positive lymph nodes, which were missed on sentinel lymph node biopsy. In spite of that, there was no difference in survival in disease-free or overall survival in these patients. Thus concluding that ALND can be omitted in early stage breast cancer patients with limited axillary disease in sentinel lymph node biopsy with either observation or axillary radiotherapy. This was a Z11 schema, which I have already discussed. The summary of this trial was that the main endpoint of this trial was overall survival, and after a median follow-up of 6.3 years, there was no difference between SLNB and SLNB with ALND. However, it had its fair share of criticism. The first was that these were good biology patients. Most of the patients were ER positive. They were early breast cancer patients. There was a short period of follow-up, because we know that hormone receptor positive patients usually experience a delayed recurrence. Up to 40% of the patients had micrometastasis to lymph nodes. This was one point which was missed on Z11 trial. Another point was that the patients who underwent mastectomy were not included. The importance of this is that all the patients underwent a breast conservation therapy, and the protocol for whole breast RT was not specified. Therefore, many of the patients received tangential RT to axilla, which was not included in the protocol, thus treating the axilla, which was not intentional. However, the working group came up with a 10-year follow-up also, and this 10-year follow-up of Z11 confirmed that the sentinel lymph nodes, which had macrometastatic disease, no further treatment of axilla was required, and this effect was sustained at a 10-year follow-up also. This was the IBC SG 2301 trial. This again showed that omitting axillary dissection when the sentinel lymph nodes only contain micrometastasis. I would like to lay more stress on the word micrometastasis is safe, because these are all good biology patients. Then came this CINOMAC trial. This is a very latest trial. It is published in New England Journal of Medicine in this year only. This is an important landmark trial because it has overcome most of the shortcomings of the Z11. They have included hormone receptor HER2 negative positive patients, but they have excluded the micrometastatic disease. Sentinel nodes with extracapsular extension were also included, and around 5% of the patients were T3, which was in contrast to Z11 and IBC SG trial, in which early breast cancer patients were included. And patients who underwent mastectomy were also included in this trial. But the result remained the same. The 5-year estimated DFS of SLNB versus observation is 89.7 versus 88.7%, thus suggesting that SLNB alone can treat stage as well as treat axilla in such patients who are clinically N0 and pathologically also, pathologically involving the up to 2 nodes only. This is again a trial which was similar outcomes, similar population, early breast cancer patients, involvement of up to 2 macrometastatic lymph nodes treated with SLNB only, and they were not inferior to patients who got their treatment through ALND. These results do not support the routine use of ALND even in pathologically positive axillary lymph nodes which are detected in sentinel lymph node biopsy. Now, this is a summary of the trials which I have discussed: the NSABP04, the B032Z11 CINOMAC, and all these trials have suggested that sentinel lymph node biopsy followed by observation is not inferior to a formal axillary lymph node clearance in early breast cancer patients with up to 2 macrometastatic pathologically positive lymph nodes. Now, what about neoadjuvant treatment? As we are treating our patients daily, more and more patients are going for the neoadjuvant treatment. Very less patients are receiving upfront surgery. And now nodal status, not only nodal status, but the biological subtype of the breast cancer also predicts its response and adjuvant treatment. Here we can see that hormone receptor positive and HER2 negative patients, only 18% of the patients experience pathological complete response, whereas it is in sharp contrast to HER2 positive patients in whom hormone receptors are negative. Close to 60% of the patients receive pathological complete response. The problem with neoadjuvant chemotherapy is that it is very difficult for SLNB to evaluate the exact burden of the disease. This was a Z1071 trial in which the false negative rate, which was well above 10%, which was not acceptable with the dual tracer technique. And the problem with NSCT was that the minimum lymph node which we should retrieve following a SLNB is at least 3, but in these trials, only median lymph node retrieved were only 2, and which was a technical barrier to SLNB alone post NSCT. These are the trials, the Sentina, the Gania trial, which all of them are showing that the false negative rate was well above 10%. Now, coming to evaluation of sentinel lymph node biopsy post NSCT, this is what we have to offer now to our patients who have received neoadjuvant chemotherapy and now who wish to undergo a sentinel lymph node biopsy. Netherlands Cancer Institute came up with this technique of marking axillary lymph nodes with radioactive iodine under sonographic guidance, and the FNR was 5.1 to 7%. The second technique is clipping the lymph nodes who are histologically positive, which was done in the retrospective data from Z1071 trial. Then another technique is targeted axillary clearance, which is being popularized by MD Anderson Cancer Institute, and the FNR is very good. It's less than 2%, in which we remove the clipped node along with this we perform the dual tracer sentinel lymph node biopsy. And last is the RESAS, it is a combination of both MARI as well as sentinel lymph node biopsy. And all these techniques have a FNR of well below 10%, maybe it's less than 5% also. And what we can see is, which was in sharp contrast to earlier studies, the MARI and the TAD techniques have an FNR of 7% and 5.1% respectively. Now, what happens if a clinically N1 disease is converting to a pathologically N0 disease? As of now, the current literature does not have robust data on this. The studies are ongoing. The NSCBP B15, in which the patients recruited are T1 to T3 with pathologically N1 nodes, which have after NSCT converted to N0. And the trial is has 3 arms, in which one arm is ALND, completion ALND, SLNB followed by completion ALND, or SLNB alone. Targeted axillary clearance is being looked in OPBC04 trial. Now, this is a very novel technique, tailored axillary surgery. This is a novel concept of clinically node-positive breast cancer, be it in upfront setting or post-NSCT if the nodes are positive. So what we do is, we selectively remove the palpable suspicious nodes, followed by removal of sentinel lymph nodes, which is mandatory. But if we have clipped any node, then that also, we remove this node also during this procedure. And there's a trial, the TAXIS trial. This is investigating whether in clinically node-positive patients, ALND can be safely omitted. Now the last question, that can we do away with ALND at all? I mean, ALND is not done in any patient. This is a sound trial which answered this question. However, the group of patients is very selective. As we can see, these are all stage 1 breast cancer patients who are postmenopausal, and the median tumor size was 1.1 centimeters, which we hardly see in our practice. All were good prognostic factors, ER positive, HER2 negative, and they suggested that 5-year DFS is similar between SLNB group and no axillary surgery group. And axillary surgery can be spared when the lack of pathological information does not affect the post-operative treatment plan, such as in hormone-positive and HER2-negative patients. Now, these are my few last slides. So this is our contemporary approach, what we do in axillary management, surgical management of invasive breast cancer. If the nodes are clinically negative, either we can go for upfront surgery or neoadjuvant endocrine therapy. Patients most likely will go a sentinel lymph node biopsy if they follow in the Z11 criteria. And ALND is done only if the 2 lymph nodes, more than 2 lymph nodes are positive. If patient receives neoadjuvant chemotherapy, then also patient undergoes a sentinel lymph node biopsy, and ALND is done even if 1 lymph node is positive. If the patients present with palpable lymphadenopathy, and they can go for upfront surgery or neoadjuvant chemotherapy. But we consider SLNB only if less than 3 suspicious nodes are present in axillary ultrasound. If the patient receives neoadjuvant chemotherapy, patients can go for a targeted axillary clearance or a MARI or a RESAS, and ALND is done only if the sentinel lymph node or the clipped node is positive. Now, coming to the conclusions, omission of axillary staging, where it may not be crucial for adjuvant treatment decisions. We can do that, as I mentioned earlier, and as was mentioned in the sound trial, that in a select group of patients, we can do that. SLNB is adequate for disease control in patients with early breast cancer and clinically N0 disease. It is adequate for disease control in patients who are early breast cancer and they turn out to be pathologically positive on sentinel lymph nodes. But patients undergoing breast conservation therapy, the margin of error is a bit higher because all these patients will receive adjuvant radiation. So the current guidelines are that the patients undergoing BCT with up to 2 micrometastases. However, patients who are undergoing mastectomy, only micrometastatic disease, if it is present in SLNB, then ALND can be omitted. There is no clear data to support omission of ALND when more than 3 lymph nodes are positive for macrometastasis. For post-neoadjuvant treatment, negative SLNB post-NSCT, ALND can be omitted provided all the technical considerations are met. We have clipped node, we are doing a radioactive marking of the node. So all these have to be done to reduce the false negative rate because post-NSCT false negative rate is very high. And positive SLNB post NSCT, I mean, there is no doubt about it. We're going to do a complete ALND. So surgery is not out of question in cancer breast. I will rest my case. Thank you. And happy to answer any questions.
So we can have one question from the audience. No? Ma'am?
In one of your slides, you talked about neoadjuvant endocrine therapy.
Yes, ma'am.
Where would you actually be giving that in? I mean, would you consider that to be a standard of care in any situation?
Ma'am, as such, we are not offering neoadjuvant endocrine therapy in our practice, but in these guidelines, they have suggested that patients who are hormone receptor positive and HER2 neu negative, these patients who are especially elderly, who are not fit for upfront surgery, these patients can receive neoadjuvant endocrine therapy. But if they receive neoadjuvant endocrine therapy, the problem with neoadjuvant endocrine therapy is that most of these patients will not show that kind of response as triple negative or a HER2 positive patients will show to a conventional chemotherapy. So therefore, SLNB is indicated in such patients. Yes, ma'am.
First of all, very nice, crisp presentation. Thank you. One thing only on the last slide that you said ki NSCT we don't know. Yes, that's very true. We don't know, but I think game ka rule hai. If you are going to do NSCT, then you have to prove node first.
Yes, ma'am.
And mapping
Definitely.
also.
Yes,
right?
Yes, ma'am. Definitely.
Okay. Thank you.
That is what I was talking about, the clipping of the node or marking of the node with the radioactive iodine.
Before NSCT.
Yes,
right. Okay.
So, in the interest
Thank
of
you, ma'am.
time, thank you, Dr. Puneet, for the excellent talk. We move on to the next talk by Dr. Rohini Khurana, Professor Radiation Oncology, RML IMS. And the topic is de-escalation strategies to manage axilla, radiation perspective.
नेक्स्ट के लिए इससे करना ओके A very good afternoon to all. At the outset, I wish to thank Department of Radiotherapy, KGMU, for having me here. It's always a pleasure to be in this department where we started our journey as radiation oncologists and in the company of our teachers, seniors, and colleagues. So thank you all. And I'm here today to talk about de-escalation strategies to manage axilla, radiation perspective. So I think de-escalation is still an experimental or thing which is in not so much in practice. So I have focused more on optimization of radiotherapy in treatment of axilla in early breast cancers. Because nodal management of early breast cancer is amongst the most vexing topics. As has been very well presented by my previous speaker, Dr. Puneet, there are a lot of surgical and radiotherapeutic studies that have given rise to numerous evidence-based axillary treatment options. And there is a profound heterogeneity in clinical practice. And although the decades of conventional wisdom, wherein we have seen that there is not much recurrence in the nodal regions after treatment in carcinoma breast, still there are various clinical practices which are there. So the roadmap for my presentation would be whether sentinel node biopsy or axillary lymph node dissection. As we have discussed, what if sentinel lymph node biopsy shows micromets or macrometastasis? Should it be followed by axillary lymph node dissection or regional nodal irradiation? nodal dissection with 1 to 3 nodes positive, then what should be the further adjuvant nodal irradiation field, as well as whether we should include internal memory nodes always in the radiotherapy fields. When axilla is treated, should we be treating the entire axilla? And post NACT, as the scenario we are frequently facing now, the targeted axillary dissection with high rates of FNRs, is it too early to be practicing it? Post neoadjuvant status, if it is YPT1, T0, N0, then should axillary irradiation be done or not? And when we are giving radiotherapy, whether it should be with VMAT or inverse IMRT, and what should be the dose per fraction for regional nodal irradiation. So as we have seen, Dr. Puneet has already told that sentinel lymph node biopsy in early breast cancer has replaced axillary node dissection as initial assessment of axilla in node negative T1, T2 breast cancer. The technique has already been discussed. When there are 2 nodes, more than 2 nodes positive, it is axillary lymph node dissection. But if there are 1 to 2 nodes positive, then these patients, they were re-examined after publication of IBCSG 2301. It was for those who had micromets, and ECOSOC Z11 for those who had macromets. Now, when no axillary dissection is done after positive SLNB, then the 3 studies, ECOSOC Z11, AATRM, and IBCSG 2301, they looked at SLNB followed by observation versus surgery. While the other 2, the Ameros and Otoazor, they looked at SLNB with micromets followed by either radiotherapy or surgery. So the Z11 patients, they had T1, T2, N0 patients undergoing conservation surgery with sentinel node biopsy. If 1 to 2 nodes were positive, patients were either randomized to have surgery or no ALND. Results published showed no difference in 5-year overall survival, and even the 10-year overall survival was similar. But the point to be noted here, as was mentioned by my previous speaker also in his slides, all these patients, they received radiotherapy for the whole breast, and in that, these tangents, they covered level 1 nodes and part of level 2 also. High tangents were also used in about 50% of patients, and 15% patients had additional SCF regional nodal irradiation also. So essentially, most of them were receiving radiotherapy to the axillary nodes. And so the Z11 patients, the eligible Z11 patients are only those who are receiving tangentials and not partial breast irradiation, and that too in supine position, not those who are receiving it in prone position. Then the Ameros trial, it randomized patients with sentinel lymph node positive 1 to 2 nodes to whole breast RT only versus whole breast RT with regional nodal irradiation, and found that there was no difference in 5-year outcomes. And even the 10 years outcomes were similar. The Otoazor trial, in which node negative and tumors less than 3 centimeter were randomized before surgery for either ALND or regional nodal irradiation, showed that axillary recurrences and overall survival were similar. And they concluded that radiotherapy should be alternative treatment for selected patients with sentinel node mets. And what should be the radiotherapy field? It can be, if there are high risk factors, then it has to be full nodal treatment, the comprehensive nodal treatment. Otherwise, it can be high tangents, and if it is a very small tumor, ER positive, it can be only tangents. EBC-TCG meta-analysis has shown that whether it is 1 to 3 nodes positive, there is benefit of axillary irradiation. The benefit is similar to those with 4 or more positive nodes. Another EBC-TCG publication lately in December 23, published in JCO, compared the radiotherapy role prior to studies 1980s, done in 1980s, and those which were done after 1989. And it was seen that radiotherapy to regional nodes in older studies increased the overall risk of death, probably explained by the radiation exposure to lungs and heart. But in more recent studies, there is reduced breast cancer recurrence, breast cancer mortality, and overall mortality. This is a direct reflection of the advancement of the radiotherapy techniques. The indications for regional nodal irradiation as per NCCN guidelines is definitely there for 1, 2, 3 nodes positive, and even if there are negative axillary nodes with high risk features, it should be considered. And also, if patients have undergone total mastectomy, then if there are there is node positive, even one node positive, it should be considered. And in negative axillary nodes, but with high risk features, it should be considered. Then next question is whether we should be treating the medial supraclavicular, the axilla, or the internal memory always. Internal memory has been shown that surgical resection of internal memory nodes is not beneficial, but RT does benefit. But the downside is, the trade-off is the high dose to the heart and the lungs. So the regional nodal irradiation with internal memory node trials were the EORTC 22922, MA20 trial, the French trial, the DBCG IMN cohort study, and the EBCTC meta-analysis. So the MA20 and the EORTC did show benefit of IMC, but the problem was the trial design was such that they were treating medial SCF as well as internal memory. So the benefit in recurrence-free and the disease-free survival was due to which specific nodal basin could not be made out. The French trial had a better design. They were giving median supraclavicular nodal RT to one group, and the other was randomized to have internal memory RT along with medial supraclavicular. But it was not, and it was underpowered, and the radiotherapy technique used was 2D. So again, there is no clear answer to whether internal memory nodes have to be always treated or they can be left out. The DBCG internal memory node cohort, it was a prospective population cohort. They said that the hazard ratio for mortality were in favor of internal memory in 3 subgroup of patients: those who had medial tumor, central tumors, and 4 or more positive nodes. So our radiotherapy to axilla and supraclavicular is to be given when 1 or more nodes are involved, T3, T4 primary, or even T2 primary with high grade ER negative, LVI positive, or central or medial primary. An entire axilla we need to treat if there is extracapsular extension. The 50% of the total dissected nodes are involved, they are positive. Perinodal tissue fat invasion or focus of invasive cancer in axillary fat. These high-risk factors have been recently brought into picture by this publication, where they have done a pathologic exploration of axillary soft tissue microenvironment and its impact on axillary management. And they found that if there is axillary soft tissue involvement or extracapsular extension, then it is associated with high distant METS rate, high axillary recurrence rate, as well as locoregional recurrences. So role of regional nodal irradiation after neoadjuvant chemotherapy, it has been discussed in the previous presentation also. Those with locally advanced are often offered neoadjuvant chemotherapy, and patients with early stage N1 undergo NACT and become YPN0 with or without PCR. There is controversial role of regional nodal irradiation. Results of NABP B51 are addressing this issue, are practice changing, as there was no difference in invasive breast cancer recurrence-free interval with or without regional nodal irradiation in certain patient population. Targeted axillary dissection needs many things in place before it is started as a routine practice to avoid false negative rates, which can be very high as 7%. So it is based on pre-op axillary ultrasound in patients undergoing neoadjuvant treatment, and it is still being explored. Chest wall and nodal CTV guidelines are there, but there is difference between RTOG and other guidelines. But at least we have guidelines to fall back on, and if we are following one guideline, then it is better to stick to that. Tangential beams or VMAT for low axilla. With tangential beams also, the level 1 and part of level 2 nodes are irradiated. But we have looked at IMRT using VMAT as a part of a thesis, and seen that if we draw the nodal volumes as per RTOG and try to cover them with tangential beams and a single anterior SCF field, then a lot of nodes, a significant volume of the nodes is underdosed. So for hypofractionation, START A and START B had fewer patients who were receiving regional nodal irradiation, and also the Canadian study had very few patients with regional nodal irradiation. So larger dose per fraction, late effects may increase, but still we are practicing, because at least in our retrospective studies, we haven't seen any downside of a moderate hypofractionation of 40 gray in 15 fractions. So to conclude, the individual decision on regional nodal irradiation should be based on risk factors. Regional nodal irradiation may replace surgery in select patients with positive sentinel nodes with reduction in chances of lymphedema. Personalized treatment is the way forward instead of one size fits all. Thank you all for your kind attention.
Thank you so much, ma'am. So at the end of the first session of the day, let us thank all the chairpersons and speakers for sharing the expertise with us. As we move forward, let's delve deeper into the scientific program. We have the brilliant minds and experts in the field, Professor Madhu Prastogi sir and Professor Sharat Singh sir as chairpersons for the next session.
Good evening, everyone. So we move on to the next session, and I have the privilege and honor of inviting Dr. Shagun Mishra, Additional Professor, Department of Radiation Oncology, SGPGI, and she'll be talking about role of SBRT in oligometastatic breast cancer.
So at the outset, I would like to thank the organizers for having me here. And I would like to congratulate the Department of Radiation Oncology here at KGMC for celebrating their 38th Foundation Day. So my role over here is to basically talk about SBRT in oligometastatic breast cancer. And let me tell you beforehand that I'm not going to cover about the technical aspects of SBRT, but more than an evidence-based discussion, because this is something that we are facing quite often in our day-to-day clinical practice. So what is oligometastatic disease? And I think all of us merely know about it. It's a state where cancer has spread to a limited number of distant sites. Arbitrarily, a numerical cutoff has been chosen as 1 to 5 metastases. And what is the clinical significance of dividing, metastatic disease into oligometastasis versus polymetastasis? The significance is basically it's thought to be some kind of an intermediate state between localized disease and widespread metastatic disease. And the approach to treatment varies. And it's the clinicians and the oncologists, they are of the thought process that possibly because this is kind of an intermediate stage, this particular state might be amenable to cure. Now, when we look at the American and the European consensus definitions as to what oligometastatic disease is all about, they do talk about a number, but they also say that it is possibly to safely deliver curative intent metastases, that determines the maximum number. So they don't give an exact number, but somewhere in the text you do find them suggesting a cutoff of 5 or less. So what is the biological basis for treating oligometastases? And when we talk about the concept of tumor evolution and metastases, a lot of basic work has been done which does suggest that there is heterogeneity within the tumor. And over a period of time, what happens is that this tumor, because it's it constantly multiplies, it acquires somatic mutations. And there is an element of selection pressure. And because of that, the mutations there are certain mutations which confers survival advantage to the tumor cells. And these mutations, the cells which are harboring these kind of mutations which actually confer a survival advantage, or just to say that the ones which are more aggressive, they are the ones who get selected over the natural process. And because they get selected, they are the ones which lead to tumor progression. And as the tumor progresses to the metastatic sites, these metastatic lesions acquire more mutations, and studies have clearly shown that the metastatic sites have a higher tumor mutation load as compared to that of primary tumors. But in this entire journey of progression, there is an early stage where the tumor and the metastatic site have not acquired all those kind of genetic alterations which allows for a widespread dissemination. So that kind of a state, if you capture the disease in that state, that is what the oligometastatic state is. And possibly if you direct your treatment aggressively in this state, you might be able to stall further progression and widespread dissemination of the disease. So again, a lot of discussion in the guidelines. When you go through the guidelines, they do talk about these oligometastatic states. So very simply put, oligometastases is limited number of metastases. Arbitrarily, the cutoff is number of metastases being restricted to 5 or less. Polymetastatic disease is, of course, the number of metastases being more than 5. Again, these oligometastases can be de novo oligometastases, that is at presentation, or metachronous oligometastases, that is something which is presenting, after 6 months of treatment or something. So this is what oligometastasis is. And the second state is oligoprogression. So oligoprogression is different from oligometastases. Oligoprogression is initially the patient has polymetastatic disease, and when the patient is subject to some kind of treatment, the primary as well as the distant metastatic sites, most of them are in control, well in control, stable. But there are few metastatic sites which progress. So that is what oligoprogression is. And it is very important to understand, because the aim of treatment when we talk about SBRT in these two different clinical scenarios is different. So if we talk about oligometastasis, true oligometastasis, the aim of the treatment is to eradicate all the visible metastases, to prolong cure, and to prolong local control, and possibly achieve cure. Whereas in a case of oligoprogression, The aim of aggressive local treatment is to, of course, control the site locally, but at the same time, there is, the aim is actually to eradicate these resistant clones so that the patient can continue the systemic treatment which the patient is on, and all the other sites are responding for some more time. So the aim is to prolong the time on current systemic therapy. The problem about the oligometastatic state is that the extent of disease is characterized by the number of lesions, and this number of lesions is basically identified by imaging. And till date, we do not have any validated markers to help guide us as to whether, when we pick up a state of disease where there has limited metastases, whether it is going to behave as such, like a limited metastasis, or whether it is going to progress into polymetastatic state. So that kind of biomarkers are not available to us. Probably in the future with ctDNA, cell-free DNA coming up, we might be more richer with our understanding of oligometastasis. A word about SBRT, and for the radiation oncology crowd, I know they are very well aware of it. It's a precise high-dose radiation therapy delivered to tumors with minimal impact on surrounding healthy tissues. The key features for the non-oncologists is basically you have fewer treatment sessions, it's highly focused radiation, and it's non-invasive, and it's suitable for tumor at various tumor locations like lung, liver, bone, brain, etc. What are the benefits of SBRT? Of course, if you treat the tumor, the metastatic site, of course, from studies, we know that the local control rate at that particular site is very high, to the tune of about 90%. There is a potential, a presumption that this might, if you treat the metastatic site aggressively, there might be prolonged progression-free or overall survival. We'll look at the trials as to what the evidence is there to support or not support this. Of course, it is minimally invasive, and for certain sites, for example, bone, if you treat them with SBRT, there is effective pain control, and there might be improvement in quality of life. So what is the evidence to support SBRT in oligometastatic breast cancer? And I'll be not talking about retrospective or registry studies. These are two randomized trials which are available to us. The first trial, the Sabre Comet, this was from Ontario. This was available to us in 2017. And this particular trial had a sample size of 99. These took patients not only of breast cancer, but this study had a wide variety of cancers included in the trial. Only 17, 18 patients were that of breast cancer, and the randomization was between SBRT to the metastatic site plus standard of care palliative care versus standard of care palliative care alone, and the primary endpoint being overall survival. The trial did suggest that adding SBRT to standard of care palliative care confers an overall survival advantage. And the median overall survival was in fact doubled in the patients who received SBRT. And then this is the second trial is a breast cancer specific trial. This was reported, I think, last year. I think it's not this year, last year, the BR002 trial. The full publication of the trial is still awaited. The inclusion criteria basically, it includes only oligometastatic breast cancer, patients who had metastases to less than 4 extracranial sites, and here the randomization was between systemic therapy plus SBRT to these local sites versus systemic therapy alone. The primary endpoint was progression-free survival, and this trial, unfortunately, did not show a progression-free survival advantage with the addition of SBRT to these metastatic sites. Let's look into these trials into a little bit of detail. The first trial is the Sabre Comet trial. When you look at the trial, only 18% were that of breast cancer, majority of them were not synchronous, they were metachronous oligometastatic disease. The median time from diagnosis to development of this metachronous state was about 2 to 2.5 years. So some kind of indolent tumors. Majority of them had less than 3 metastases, and the most common site of metastasis in this particular trial was lung and bone. It's also important to see that this trial was done in a proper control setting, yet the grade 5 toxicity was to the tune of about 4.5%, and grade 5 toxicity, let me remind you guys, it includes death. So about 5% deaths. And when you look into the trial into further detail, this trial does suggest that in that small subgroup of breast cancer patients of about 17 patients, the total trial was just 99 patients, there was no difference in outcomes in terms of overall survival. When we look at the second trial, the BR00 trial, very similar kind of a trial design, wherein patients were randomized into standard therapy versus standard therapy plus ablative therapy to the oligometastatic lesions. The median age was, in this particular trial was 54 years, but this was just an oligometastatic breast cancer subtype. Majority of them were hormonal receptor positive tumors, and the median follow-up of when the trial was reported was 30 months, and this is something which I got from the net because the full publication is still not available to us, and this trial did suggest that there is no difference in the progression-free survival as well as the overall survival. What the trial also did suggest that actually the standard of care, they had presumed that the median survival would be about 10.5 months, but actually the observed survival in the standard of care arm was quite high to 23 months because of the use of effective systemic therapies. Also to note, there were no survival differences. Of course, the local control, because you're treating the oligometastatic site, it's going to be high. And also important to note that the grade 3 or more adverse events with the use of SBRT is doubled. It's from 5% to 10%. Again, you know, you should be careful when you're using SBRT outside a clinical trial setting. So the conclusions of the trial was that there were no progression-free or overall survival benefit. Routine use of SBRT off protocol in case of oligometastatic breast cancer is not recommended. Again, when you go through the details, they did a exploratory analysis for the TNBC subgroup, which comprised a very small population, about 8%, and what they saw that the use of SBRT actually to this subgroup using SBRT was worse. Continuing with standard of care chemotherapy was better in this particular subgroup. Now, this is about oligometastases, and let's talk about progressive breast cancer. And typically, the outcome over here is to improve the progression-free survival or to delay the time to switch to further systemic therapy. And there is limited data in breast cancer. There is promising data which is available from non-small cell and prostate cancer, the ORIEL trials in oligoprogressive setting. In breast, we have the CURB and the AVATAR trials. So what is CURB? CURB is consolidative use of radiotherapy to block oligoprogression. This was again a phase 2 randomized trial wherein they took patients of oligometastatic non-small cell lung cancer and breast cancer, wherein patients who had received systemic therapy and they had progression in few sites, they were subjected to SBRT versus change of systemic therapy, and the primary outcome of this trial was progression-free survival. The trial in the lung cancer subgroup, it did show improvement in progression-free survival, but in the breast cancer subgroup, the addition of SBRT did not show a progression-free survival advantage. What are the salient features of this trial? There were few lines of systemic therapy, about 3 to 4 lines of systemic therapy which were used in this trial before they were subjected to inclusion, and what's thought is probably it was a very resistant population that we were dealing with, and about 34% of the patients in this particular trial were triple negative breast cancer. This trial did suggest that possibly the time to initiation of systemic therapy or change of systemic therapy was delayed with the use of SBRT to the oligoprogressive sites, and this was to the tune of about 3.9 to 4 months. So conclusions from this trial: no progression-free survival benefit to SBRT in oligoprogressive breast cancer. Possibly it might help us delay in switching the therapy, and that's also an important endpoint because many of these hormone receptor positive tumors, they are on oral endocrine therapy, and if you switch therapy, they would be subjected to some kind of injectables. So possibly endpoint to look forward to. Additional considerations from this trial was that many of them had received prior lines of chemotherapy, so possibly we were dealing with a very resistant population of tumor cells, and 30% of the patients were triple-negative breast cancer, which is possibly a aggressive subtype. And this is another phase 2 single-arm study, the Avatar trial, wherein patients with ER-positive progressive metastatic breast cancer who had received at least one line of systemic therapy and progressed, they were subjected to SBRT with or without CD4K inhibitor. And the primary outcome was event-free survival and time to change of systemic therapy post-SBRT. And the median time to change of therapy was about 10.4 months in the trial. They had said that if the time to change of systemic therapy is more than 6 months, then possibly SBRT is an effective treatment, and that is what they achieved. And possibly in this luminal subtype of breast cancer, adding SBRT to the oligoprogressive lesions might delay change in therapy. What about local control and safety of SBRT? And we have a systematic review and meta-analysis, which does suggest that it is a very effective treatment in terms of local control. The grade 2 toxicities are minimal. Some of the registry studies suggest a grade 3 toxicity of less than 0.5%, but other registries do suggest that there is a grade 3 toxicity of 4 to 5%, so you should be careful, and it should be in a very controlled setting when you're using SBRT as a routine in your clinics. What about use of systemic therapy with SBRT? And there is, of course, a risk of interaction between systemic therapy and radiation. There might be a radiation recall. There might be worsening of toxicity if you're using systemic therapy. So generally, they say that you should be holding systemic therapy for the duration of SBRT, and it can be approximated by the half-life, generally 3 to 4 half-lives. The ESTRO 2024 came up with consensus recommendations, and generally what we can make up from the recommendations is that the CD4K6 inhibitors along with SBRT might be okay. PIK3 inhibitors might not be okay. mTOR inhibitors are not okay with SBRT. Most of the HER2 new drugs are okay, whereas the newer drugs like tucatinib and neratinib, the efficacy has not been established, and the antibody drug conjugates should not be used concurrently with SBRT. For PARP inhibitors, we have little data available, and immunotherapy probably might be okay when you're using SBRT. This field is evolving, and in the near future, we might get more answers as to which drugs can be safely combined with SBRT. This is my concluding slide. SBRT, of course, is effective in controlling the local, the distant metastatic site with limited grade 3 toxicity. Randomized trials as of now do not show an advantage of SBRT in terms of overall survival or progression-free survival, both in the oligometastatic or the oligoprogressive breast cancer. It might prolong time to change of systemic therapy in a luminal subtype, which might be an important endpoint because you might change from oral to injectable. We don't know. There might be specific subgroups where SBRT might improve organ outcomes, maybe de novo metastatic disease, maybe a HER2 subtype or the luminal subtype. My take-home messages are routine SBRT generally should not be given to asymptomatic patients with oligometastasis or oligoprogression, and only in those cases, for example, bone mets or brain mets, where there is a benefit of local control, there it should be offered. Thank you very much.
Thank you, Dr. Shagun. That was a very crisp presentation, and time for just a very quick question or a comment. Yeah.
Only quick, Sagun, quick explanation, or you can say oligo means 5 sites, number is okay.
So the definitions are based on the number of beds.
Number is okay.
So
number I accept 1 to 5.
1 to 5 and less than 3 organs.
Less than 3 organs. So
Yes.
if patient has a brain, patient has lung and bone, so she qualifies for oligo.
Yes, she does qualify for oligo. So it's an evolving field. So we really do not know, we do not have all the answers. But that's an arbitrary kind of a cutoff that we have established. And that's the problem.
Ma'am, would the site involved in the oligometastatic site would also affect the nature of the disease? Like if the oligometastatic site is involving it's the liver, in that case, would it also impact, should we consider that as oligometastatic, or should we rather approach it to be as a case of more frank metastatic? Because liver is a more site which is...
I hear you. I mean, you mean to say that whether bone metastases would behave more like a true oligometastasis as compared to that of a liver mets?
Yes, ma'am.
So yes, bone metastases in general has a better survival as compared to that of liver mets, but whether the approach should be different is not been proven by trials. In the HR positive study, majority of these studies of oligometastatic breast cancer have taken bone metastases, yet offering SBRT over standard of care systemic therapy has not conferred a survival advantage or a progression-free survival advantage.
I actually asked this question because we came across a case of breast cancer who was HER2 positive and had one systemic metastatic site in the liver only. And so I was having doubts whether we should approach it as oligometastatic or metastatic, or should we go like in terms of the approach to therapy, should we keep it radical or palliative?
So we also do face it day in and day out as to these limited metastases, particularly the de novo oligometastases, as to how to deal with them. Should we actually treat them the radical pathway, or should we treat them like a metastatic disease? And unfortunately, the answers are not there. I think that's where you need to have a MDT discussion and probably have kind of a prospective registry for these kind of cases and see as to what their outcomes are.
Okay. Thank you, ma'am.
Thank you, Dr. Shagun. May I have the opportunity to invite Dr. Anand Mishra, Professor and Head, Endocrine Surgery, KGMU. He'll be speaking on the recent development of subcutaneous dual HER2 blocker. It's a new thing which can be given subcutaneously, the dual HER2 blocker.
So, pen drive खोलो मेरी, चश्मा निकाले. हाँ ये इसमें first देखो. हाँ ये. So very good afternoon and thank you, Dr. Kirtis, Dr. Rajiv, for giving me this opportunity. So there are some, I can say, disclaimers. One is that I am just a speaker on behalf of Roche. These slides are provided by them, and then they were provided only 1 hour before this, only in the afternoon. And the third thing is, many things you all know. So since it's a sponsored talk, I will hurriedly run through some of the things. There are 3-4 aspects when we talk of HER2 blockade in HER2 positive breast cancer, and that is more important for residents. What is the evidence for HER2 blockade? And then why the dual blockade? Then advantage of the dual blockade, IV versus subcutaneous. And how do we do it? There is the difference of dose between the two. It is a subcutaneous is a fixed dose formulation, while IV is a different dose. So how do we calculate those? So those all aspects just I will like to highlight. So thank you, Roche, for giving me this opportunity. Advantage of subcutaneous dual HER2 blockade in HER2 positive breast cancer. That was a disclaimer. So we have evidence of treatment landscape. What is the standard of care in HER2 positive? We have that evidence from three trials, and then there are some additional supporting studies, Neosphere, Affinity, and Cleopatra. They have provided the main evidence that it should be used, it should be a standard of care, and we should use these HER2 blockade in these patients. And they have provided the evidence that PCR is more if we use dual blockade. There is more overall survival, and so basically, if you see, it should be used in neoadjuvant setting, and in all newly diagnosed HER2 positive breast cancers, if they are more than 2 centimeters or N positive disease, they should receive HER2 blockade therapy. And it should be initially a combination of pertuzumab, trastuzumab, 6 cycles, followed by surgery. And if patient has, there can be 2 situations. One is PCR and other is residual disease. If it is PCR, then again 1 year pertuzumab therapy or 18 cycles of pertuzumab therapy combination, pertuzumab or trastuzumab therapy, or pertuzumab for at least for 1 year and trastuzumab for 18 cycles. If patient has a residual invasive disease, then obviously treatment changes. In place of trastuzumab, we go for TDM1 therapy. Now the second situation is that patient is clinically T1, then it is N0 disease, and we have done surgery. In that situation, this blockade is used as adjuvant setting, and 18 cycles of pertuzumab, trastuzumab based therapy should be given in these patients. So that was the standard protocol. Now trastuzumab and pertuzumab combination is well established by these all studies. There are some challenges regarding the doses and infusions, then how to give them through the catheters, access, venous access means catheters through the venous access or subcutaneous. And Fasgo is one of the product formulation of the products of two antibodies, pertuzumab and trastuzumab, and it has been combined with a biologic and given in one vial for subcutaneous injection. Now, what is that biologic? The biologics they have developed, and it is there in that vial that combines these two antibodies. And with this, if you see the duration, it takes a long duration in processing and producing these product. Multi-step process, 6 to 8 months it takes only host cell, then fermentation, and then purification, and then further 2 to 4 months in this formulation. So a detailed process is involved, and after that we get that product. Now, if you see the pertuzumab, both have action on HER2 antigen, but they have different place. Pertuzumab is designed to work with trastuzumab for a dual HER2 blockade. In preclinical models, pertuzumab targeted a different subdomain on the HER2 receptor than trastuzumab. So that's the advantage in these patients. If you it can be seen very well with the diagram. With this combination, they have this RHU PH20, they make it, and on the subcutaneous injection, and this can take large fluid volumes. And by these 3 diagrams, they have explained only if you directly give any injection subcutaneously, you can give less than 1 ml or 1 ml. But if you combine this with this pH20, then you can give larger amounts of fluid to the subcutaneous plane. And after this subcutaneous administration, the architecture of the skin is reformed within 1 to 2 days due to rapid clearance of this and fast hyaluron turnover. So this formulation allows subcutaneous administration of large volume fluids, more than 1 ml. And basically it is 10 ml when you inject these solutions. So without an injection, that's a picture diagram. It will give you a bleb and it will take a long time for the absorption. But if you combine with RHU, so before infusion and after infusion, you can see. Basically, this injection is given in the thighs, so it's a picture of hand. Now, the third issue was how do you decide the pharmacokinetics, efficacy, and safety of subcutaneous formulation versus IV formulations. And if you see the dose of this subcutaneous is fixed dose combination, 1200 milligram pertuzumab and 600 milligram of trastuzumab is given in the loading dose, and then 600 and 600 combination in the maintenance dose. While if you go by IV formulation, so Perzeta, it is available as the Perzeta, and it is 840 milligrams as a loading dose and 420 milligrams, depend on the milligram per kg body weight. So Perzeta you give 840, and then for trastuzumab it is 8 milligram per kg as a loading dose, and then maintenance dose is 6 milligram per kg. So these doses have been, they have compared these doses by these studies. FIDERICA, phase 3 non-inferiority study assessing the PK, efficiency and safety by this study. And through various endpoints, they have concluded that serum values in the patients, and then ultimately it was the output effect of side effects we have to see, and then clinical effects. And if you see all side effects, depending on more than grade 3 side effects or serious side effects, they are comparable in both groups. Whether you give first group is Perzeta plus trastuzumab IV, and then second group is subcutaneous group, and it is comparable. If you see individual cardiac events, primary cardiac events, secondary cardiac events, or ejection fraction events, they are also comparable in fixed dose formulations as well as IV formulations. There was one more side effect slide. It is missing. Okay. So this shows that it is non-inferior. This combination, subcutaneous combination, was non-inferior to pertuzumab, trastuzumab IV based on cycle 7 pre-dose. These things, then PCR rates were also nearly identical compared to the IV, and then safety profile was also comparable to the IV doses, if you see by this study. Then the next question was, do patients prefer this subcutaneous dose in comparison to the IV dose? For that, they have a study has been done, Franica SCA study, and it is also a phase 2 study, and in which they wanted, they have selected the patients and given 18 cycles of this subcutaneous versus IV. If you can see, the primary objective was patients' preference to the subcutaneous dose, and ultimately the result was that patients were in favor of subcutaneous dose, but it was a preferred route and preferred drug in these patients. Then time has been calculated in this study, drug preparation time and treatment room time, and then observation time. And obviously in subcutaneous dose, this was less. There was less time in subcutaneous. For IV preparation, you need to have 15 to 20 minutes, and then 130 to 300 minutes for preparation and infusion, while in subcutaneous dose, it is only 5 minutes preparation and then 30 minutes infusion time. So 85% of these patients, out of 160 patients, 136 patients preferred the subcutaneous dose in comparison to the IV dose. There was more patient satisfaction. Then what is the practical consideration? These are the just tips how to use these drugs. I'm skipping this. The standard guidelines where to give these drugs. So obviously in thigh it is being given. How do you make a bleb? So you put this, give this injection in subcutaneous plane, and after giving the injection, you have to keep your patient for observation for at least 15 minutes. That is the important point. And then this dose can be given in outdoor settings also. You don't need many things. So if we summarize all the benefits in cost, time, and reduction of patients and healthcare patients burden, shorter administration time 5 to 8 minutes, 15 to 30 minutes observation time of PHESGO reduces the burden on patients, cares, and providers. It is less invasive administration because it is single subcutaneous injection versus IV, 2 separate IV infusions. It is a fixed dose formulation, and it may help reduce risk of dosing errors, reduce drug wastage, and increase availability of nursing pharmacy staff for the task. Reduced time required for drug preparation and administration with PHESGO versus IV has the potential to relieve strain on infusion centers. And no new safety signals have been observed when switching from IV to PHESGO and vice versa. So it is if you see the PCR rates, that's important for our clinicians, that PCR rates are identical between subcutaneous dose and IV doses. And with this, I thank you all for giving me this opportunity. Thank you, Dr. Rajiv. Thank you.
Thank you, Dr. Anand, sir.
With this, we come to an end of our second session. Please join me in thanking our chairpersons for conducting this session in a brilliant manner. To start our next session and lead us on our journey of learning, we invite Professor Punita Lal ma'am and Professor Neeraj Rastogi sir as chairpersons for our final session.
Good evening. For the next session, I am inviting Dr. Teesraj Verma, who is a professor of physics in the radiation oncology at KGMC. He will be talking about the implementation of DIBH in routine practice. Dr. Teesraj.
Good evening, everyone. I am Dr. Teesraj Verma from Department of Radiation Oncology, and I will be speaking on, in fact, I will be sharing on my experience on implementation of DIBH in routine practice in our radiation therapy facility. Before I open up on my talk, I would like to extend my heartfelt thanks to Professor Rajiv sir and my dear Sudhir Singh sir for giving me this chance. So I would be open with the RT mandate, RT principal mandate, which requires maximum dose should be delivered to the target and minimum dose to the OAR. And that is for in general and in particular for left breast radiotherapy also. However, during left breast cancer radiotherapy, heart and lung, like OARs, also get some significant dose sometimes, and that is why radiation-induced heart diseases has been reported more in case of left breast cancer radiotherapy. So now, in line of mandate of radiotherapy principle, what are the methods that that can be utilized for reduction of dose to heart during breast cancer radiotherapy, especially left-sided? So there have been time to time number of methods introduced, utilized, and one of these is volunteer DIBH, which have been reportedly very effective. Then, what this VDIBH is exactly? This volunteer deep inspiration breath hold technique. Actually, under this technique, patient is asked to inhale deeply, sufficiently, and inflation. And during this inhalation, lung inflates, and due to this inflation, heart moves away from the chest wall. And here we can see that. After inflation of the lung, heart moves away from the radiation beam, and that results in lower reduced dose to the during left breast cancer radiotherapy. So here I can show on my slide that in lower side, that is in a pre-breathing setup, comparatively larger volume is irradiated compared to DIBS setup. So that is how this VDIBS practice can be utilized for reducing the heart dose involvement during left breast cancer radiotherapy. But this is not as simple as that, as I am iterating here, because of many challenges. So let me walk you through this process in my subsequent slides. So here are the number of steps that are being utilized in case of general radiotherapy, and these are the major steps that are followed for any cancer site, irrespective of technique used, irrespective of cancer site. But the patient who undergoes VDIBH need to undergo these some additional steps, that are 4 additional steps shown above. And the patient undergoing VDIBH are routed through these 4 processes, and ultimately comes in the main earlier routine process of steps, like I shown here. So as far as its implementation in routine radiotherapy is concerned, as soon as patient is qualified for radiotherapy, then patient is given an option of VDIBH, where patient is counseled about its benefit, its advantage, what will be the advantage, and what will be the cooperation needed during this process of operation. So patient is screened carefully to tolerate the technique, patient convenience, then potential benefit, and based on the tumor size and type of tumor. So once patient says and gives her willingness to get in under this VDIBH process, a written consent is taken, and along with other medical records. So after the consent taken, patient is counseled, and in fact, patient is trained and coached about the familiarization of the process to be followed during this VDIBH process. And during this training and coaching, inhalation, breath holding, exhalation exercises are given just to come up with the adequate breath holding sessions during the VDIBH process, basically. And this is done with the help of pictures, video, and verbal conversations, and giving the answers to all the questions raised by patient during this training and coaching. So, and overall, the patient is instructed to build up its capacity to have breath holding capacity at least for 20 seconds during this whole process of DIBH. And this can be done with the help of exercises, yoga, and spirometer exercises. But patient is emphasized to patient is instructed to do all this exhalation, inhalation, and breath holding processes with the instruction that you are not allowed to arc your back during this process, you are not allowed to shrug the shoulders during this breath holding process, and then you are not allowed to breathe from your belly, and you are not supposed to be, you are not go to tense during this whole process. Otherwise, the whole of the exercise may be deteriorated and the expected intended outcome may be different from that one, what we have started with. So after this all coaching training and satisfactory answer to questions of the patient is asked to revisit, asked to go back home and do the exercises and training to strengthen and build up the breath holding capacity at least for 20-second duration. And again, and after this, patient is asked to revisit for its next step, which is simulation, which is one of the very important step of radiotherapy process. So during simulation, patient is supine on a flat couch with both arms above the head, generally what we follow in case of pre-breathing radiotherapy, breast cancer radiotherapy. And here, with the help of audio-visual assistance, that is coupled with the real-time monitoring of the DIBS depth. And here, DIBS depth is taken from a reference point, which is defined as mid of the xiphoid process and umbilical. So, patient setup is exactly done what it will be during the actual radiotherapy process. And here, with the help of audio-visual assistance, according to the preset previously given training and coaching, patient is asked to inhale slowly, and as soon as patient reaches to the preset depth, then CT scanning is done. And this CT scanning is done for both the free breathing setup as well as DIBS depth, DIBS setups, having all generally 5 millimeter thickness of slices of CT scan. So as soon as CT scanning is done, as in general routine we follow, these CT datasets are transferred to the treatment planning system where 3D CRT treatment planning is done. Generally, this DIBH is compatible with VMAT as well as IMRT, but at our facility we use 3D CRT technique for treatment planning. Then here during the planning, we try to optimize the dose rate to reduce the effective time, treatment time, and to avoid the field-in-field approach. Generally, we come across as in case of CA breast radiotherapy because of large inhomogeneity and contour variations. So 3D CRT with the help of this one medial tangential and one lateral tangential, and as per the case, SCF field is utilized, giving the routinely followed margins in this case also, and a plan is generated for 42.5 gray in 16 fractions. So as followed in routine pre-breathing setup, treatment plan is finalized, and once treatment plan is finalized, it is transferred to the treatment console. However, I would like to add one more thing, that here we do plan for pre-breathing setup as well as DIBS setup both because of the reasons to get what will be the effective gain during this whole process, just comparing it with the hard dose comparisons. Next, treatment plan is transferred to the treatment console, generally as we do. And here again patient is asked and patient setup is once again maintained at the treatment unit again, like it was maintained at the time of simulation. So with the help of audio-visual assistance, once patient is ready inside the treatment room, and with the help of audio-visual assistance, coupled with the real-time monitoring of the DIBS depth, patient is again asked to inhale slowly as soon as the patient reaches to preset level of DIBH, what was maintained at the time of simulation, then treatment beam is made to on. So here is, I have taken a video, but sound I don't think here. Can I have sound? So here I have taken a video just to let you go through what happens really during the radiotherapy execution. Patient is ready and everything set up according. So that is how treatment is done. Let me reiterate for you because of some technical reason, maybe it was not that much audible. But the setup is ready, again ready just like treatment, just like simulation stage. And as soon as patient inhales at the preset level, treatment beam is made to fire. And here I would like to mention that maximum 20 seconds in one go is treated because of earlier coaching instructions. So coming to result, what is the overall outcome of this whole exercise? And this is, I would like to say, this is one of the most loved slide overall from this presentation because of the significant reduction in the heart dose during this whole exercise. So here saffron color is showing heart dose with the DIBS setup, and blue color is showing heart dose with the free breathing setup. And we can notice here as much as 51% dose reduction have been achieved, ranging from 15 to 61%. And also this is most satisfying because of the reason that for what objective we started with and we have achieved. So, and that is why, and also because of the reason that VDIBH is not new. The concept, the idea is not new, but the way we started and executed it by developing in-house hardware system coupled with software and application of AI is most satisfying because there are parallel commercially available equipment for the same purpose like ABC, which are invasive in nature, and like RPM, they are time consuming, very sophisticated and costly also. And that is the reason I am saying it is one of the most satisfying slide because of the objectivity and the result we have achieved so far. So in radiotherapy, there is a issue or better to say challenge of reproducibility over the number of sessions, and that is what makes difficult and challenging. So here in case of VDIBH, this challenge gets multiplied because in general in radiotherapy we need to reproduce the setup, anatomical setup, but here in DIBH we need to reproduce the breathing pattern basically, and that is why this whole process get multiplied in terms of challenges. And just to emphasize you that these reproducibility has to be maintained not only single times, but this need to be reproduced exactly in the same manner during whole of this 16 fraction. For example, in the case of CL left breast cancer radiotherapy. And the things are more challenging even because of the requirement of 5 to 7 times of breath holds sessions during the 1 fraction of radiotherapy treatment. And even a millimeter order accuracy, in fact I should say millimeter order error may impact the outcome for what we are intended and you started with. So that is why this is one of the very challenging tasks, and that is the reason I think probably the DIBH is not has gained that much popularity and has been utilized that much. So here is the testament to our work, what we have achieved in terms of breathing pattern reproducibility. The first 2 breathing pattern is of the same patient, but at the different breath holding session. Here we can see clearly that the breathing pattern is completely not equivalent to each other, though it is of same patient. And that is what I'm trying to emphasize, that how much it is challenging basically. The same patient is having slightly different breathing pattern, though it is completely under tolerance. But some patients perform wonderfully, like on the screen, we can see here completely almost straight line throughout the 20 seconds of breath holding. And that is what we have achieved by in-house developed equipment, software and hardware. And that belongs to own, and that is unique for us. And that is why I'm saying that it is most satisfying. So this is another patient which having some variation during its breath hold during 20 seconds of duration. Maybe though it is having slight variation, over the 20-second duration, but it is completely within the tolerance limit of ±2 millimeter. Again, the setup reproducibility is also like in general, in routine we follow for the anatomical setup also. So for that also we have done and we have followed the same routine process. And here is the testament again, testament to our hard work and dedication, that is showing a very little difference, little deviation between the simulation and treatment sessions. And these deviations are completely within the tolerance limit that is prescribed for this process. So coming to my last slide of this presentation, that is take-home message, and better I should say lessons learned so far. So DIVH is completely non-invasive and a quality treatment in cost-effective manner. Yes, having said this, this is completely in-house developed system, and the result is as good as state-of-the-art technology equipment available commercially, that are costly, time-consuming, and sophisticated as well. And that is why we can deliver cost-effective treatment in quality treatment in cost-effective manner with the help of VDIBH. Next, what I learned is experienced team is critical to ensure the VDIBH technique is properly implemented. Yes, no doubt, like in other skill, other job, other task, other place, experience matters a lot. Here also, once again, experience matters a lot. For example, experienced team can handle the patient and can bring the patient to same level of understanding, good level of understanding for about the DIBH and how to perform the breath hold and what will be the impact if you are not performing the optimally. So proper training of the patient and the use of audio-visual feedback communication skill is utmost important. Yes, it is the effective communication, I would say, effective communication skill that brings all the patient, irrespective of their educational, irrespective of social, irrespective of their financial level, to the same level of understanding for VDIBH and breath holding reproducibility. Proper quality assurance and training are needed to ensure safe and effective VDIBH breast treatment. Yes, I used to say what we see, what we know, and what we know, what we do. Yes, there should be stringent quality assurance tool, and until unless it is not there, we will not in position to let us know whether we are going in right direction or there is some chance of improvement for better radiation delivery. And at the last but not least, patient cooperation and compliance with DIBH treatments are very important but extremely challenging. Yes. Thank you once again for your patience listening. Thank you. Any question?
Thank you very much, Dr. Tirthraj. Very simply put, very nicely, and your hard work did show. And I really like the caption, the last caption that you've said. I don't know if there are any questions. I'd just like to say one thing, just to a quick comment, and that is that DIBH is so very important and so simplistic in a procedure, but it yields very good result. Having said that, patient selection is very important in
yes,
this.
ma'am. Yes, ma'am.
Yeah. So, thank you very much.
Thank you, ma'am.
So we come to the last speaker of the day, that is Dr. Amit Chaudhary, who's a consultant in medical oncology and hematology at Globe Cancer Center, Lucknow. And he's going to talk about CDK4 inhibitors, 4/6 inhibitors in CA breast. Dr. Amit.
Thank you. First of all, I would like to congratulate the Department of Radiotherapy, KGMU, for celebrating the 38th Foundation Day. And I would also thank for inviting me, for giving me this wonderful opportunity to speak about this wonderful molecule, CDK4/6 inhibitors. So, breast cancer has seen a lot of transformation over the past so many years. It was 1900 when the first knowledge about the treatment of breast cancer, which can be surgery by the removal of the echelon nodes, and which can cure the breast cancer. Initially it was thought, and since then it's 2024, and we have seen so many advances in the field of breast cancer, whether be it adriamycin with cyclophosphamide, with the introduction of taxanes, there have been improved survival rates. Then we have come to the dose-dense chemotherapies along with the support of GCSF, which again has survival benefit in the ER positive early breast cancer. Then we come to the era of trastuzumabs, pertuzumabs, trastuzumab deruxtecan, trastuzumab emtansines, and then now we have immunotherapy for triple negative breast cancer along with the PARP inhibitors for the BRCA mutated disease. Also, we have been able to provide better quality of life with better toxicity management, whether be it romiplostim or GCSF or darbepoetin alpha. These kind of molecules have been brought, and which has led to improvement in the quality of life, lesser toxicities, and further leading to improved survival also. So what are the basically treatment goals in a metastatic breast cancer? So this was a physician's survey, and it was seen that most important treatment goals were prolonging the life, preserving the quality of the life, and improving the quality of the life. So considering these facts, and also based on this questionnaire from various women with metastatic breast cancer, most women said survival was the most important factor, and they with expressing a willingness to trade off the side effects and prolonging their lives. So lengthening the survival is the most important consideration whenever we talk about the metastatic breast cancer. And as we know that what is overall survival? It's the time from the randomization until death from any cause, and is measured in the intent to treat population. So why we need this CDK4/6 inhibitors? What is the need, first of all? So in patients of metastatic breast cancer, whenever we give chemotherapy, it's not only that we give just the chemotherapy. We are giving the side effects. We are giving alopecia. We are giving mucositis. We are giving diarrhea. We are giving hospitalizations. We are inserting chemoport. We are doing PICC line. These all factors are also given along with chemotherapy. So what if we can give an oral drug which not only improves the quality of life, not only improves the progression-free survival, it also improves the overall survival. So definitely CDK4 inhibitors, they have changed the entire landscape of the metastatic breast cancer. The postulated mechanism for this CDK4/6 mechanism inhibitors is a CDK4/6, these are the cyclin-dependent kinase 4/6. They form a complex with cyclin D. And this complex, they enter the cell cycle, and it phosphorylates the RB protein. RB protein, it is a tumor suppressor gene. So this results in the phosphorylation, results in the inactivation of the RB protein, and this inactivation leads to the transcription of the gene and progression of the cells from G1 to S phase. And thus this progression leads to the cell cycle, it initiates forward and leads to tumor cell formation. These cancer cells, when we give CDK4/6 inhibitors to the patient, this complex is inhibited. And whereas the RB protein is active in such patients, and the cell division is halted. Now, we are interested in just 3 molecules. Currently of clinical importance are the 3rd generation CDK4/6 inhibitors, which are the palbociclib, ribociclib, and abemaciclib. So, few points regarding the pharmacological properties of these drugs. And what we know from the preclinical studies, that CDK4 is more important than CDK6 in breast cancer. Because in the cell lines of the breast cancer cells, CDK4 was more prominent as compared to CDK6, whereas CDK6 is mainly present in the hematopoietic cells. When we talk about the 3 molecules, ribociclib, abemaciclib, and palbociclib, ribo and abema are more active against CDK4 as compared to palbo. The third point is, when we have the kinase inhibition by these drugs, ribociclib and palbociclib, they have fewer off kinase interactions. Basically, it shows that the side effect profile of ribo and palbo will be better as compared to abemaciclib. Last but not the least, if we measure the serum concentration of the drugs, ribociclib has shown to have the highest concentration in CDK4 inhibition as compared to the palbociclib and the abemaciclib. These are the few phase 3 trials of CDK4/6 inhibitor with the aromatase inhibitors when combined with the aromatase inhibitors, which includes the Mona Lisa, Paloma, Monarch, and the Mona Lisa 7. And if you see with fulvestrant, when these CDK4/6 have been combined, they have been used in the first line as well as in the second line, and we have got the survival benefit in few of them. Coming to individual trials in very, very short. So Paloma 1, it was a palbociclib trial, phase 2 trial. When palbo was combined with letrozole, there was an improvement in PFS, no benefit in OS. In fact, OS was not studied there also. To verify the Paloma 1 study, Paloma 1 study, the phase 3 of Paloma 2 was done. Again, there was a benefit in the PFS with a hazard ratio of 0.58. When palbociclib was combined with fulvestrant in the Paloma 3, again there was a benefit in PFS with a hazard ratio of 0.5 and well-tolerated side effect. In Asian population, palbociclib was combined with letrozole, and again we had seen the PFS benefit was existing with a hazard ratio of 0.68. Similarly, when we see the ribociclib trials, when it was combined with letrozole, again the better thing in this trial was the Mona Lisa 2 trial, there was OS benefit with a hazard ratio of 0.76. And when ribociclib is combined with the fulvestrant, in more than 700 patients, there was OS benefit with a hazard ratio of 0.73. Definitely very encouraging results, and we are using these drugs more and more commonly in our practice. And if we see the Mona Lisa 7, in fact, all the trials which I have told you previously, they were done in postmenopausal women. But Mona Lisa 7 included women who were premenopausal. So even in premenopausal, ribociclib, when combined with the endocrine therapy, included these patients also had a survival benefit along with the PFS benefit with tolerable side effects. When talking about the third molecule, that is the abemaciclib, again the results are fascinating. If you see that when combined with fulvestrant, there were the response rates gone up to 50%. This is very important when we are treating patients those who are having visceral metastasis. In visceral metastasis, we need response rates, liver mets, lung mets. These patients, there is a tendency for us also to give chemotherapy in such patients because we want response rates. But having a response rate of 50%, it's more than the taxanes, it's more than the anthras, it's more than the other chemotherapies which we use. So definitely, these drugs are going to become gold standard in coming future. Again, one more trial for abemaciclib with Monarch 3, and we clearly see the response rates going up to 60% with a PFS benefit with hazard ratio of 0.41. So in all the trials which I have discussed, PFS benefits is almost the same with hazard ratio of 0.5, but the OS benefit exists in the ribociclib with Mona Lisa 2, Mona Lisa 3, Mona Lisa 7. These all trials have shown OS benefit along with abemaciclib when combined with fulvestrant. But with palbociclib, the thing is we have no data for OS benefit. Although the generic versions are available, so we are using more and more commonly because it's cheaper. But if we really go into the data and if we really want to explain to the patient regarding the OS benefit, which I had shown in the first slide, that in metastatic breast cancer patients, OS benefit is something we really want to give. In that case, ribociclib and abemaciclib when combined with fulvestrant and ribociclib combined with fulvestrant or an AI, they give the survival benefit. So my choice in metastatic setting, first line, hormone positive, HER2 negative, will be ribociclib with either fulvestrant or AI or TAM. Now, since the metastatic settings, we have these drugs now used in adjuvant setting also. And in adjuvant settings, there are 4 trials, out of which 2 are positive and 2 are negative. Monarchy is adjuvant abemaciclib in early breast cancer patients, and Natalie, the 4th one, is adjuvant ribociclib for 3 years in early breast cancer patients. Whereas the Panoply and the Pala trial, these are the palbociclib adjuvant trials, but these were negative trials. Very shortly, I'll tell you, the Monarchy study here, we had given adjuvant abemaciclib to patients who had more than 4 axillary node positive, or if 1 to 3 axillary lymph node positive, they were at least a grade 3 disease or tumor size more than 5 centimeter. And the cohort 2, if 1 to 3 axillary node positive, in Ki67 more than 20%, we had given this abemaciclib 150 BD for 2 years, and what we saw is that there was 32% reduction in the risk of developing an IDFS event. The curves are still separating, and at 5 years you can clearly see the number of events in the Abhima arm was far less as compared to the ET alone, and it was 7.6% better at 5 years. And the last trial which I want to tell is the ribociclib. Ribociclib, when given for 3 years in adjuvant setting, the better part in this trial was they included N0 patient also. In abemaciclib, they had not included the N0, but in ribociclib, they had included the N0, and the dose was less here. It was 400 milligram per day for 3 weeks on and 3 weeks off. Sorry, 1 week off. And again, in this patient, in these set of patients, the risk of invasive disease was reduced by 27% in the node negative and by 24% in the node positive disease with the ribociclib. Clearly, CDK4/6 inhibitors are now one of the category 1 recommendations as per the NCCN guidelines, and also as per the ESMO magnitude of clinical benefit scale, the ribociclib and the palbociclibs, they get very good ranking as per their responses. Thank you. Any questions? Thank you, sir.
Thank you so much. We hope that the insights and expertise shared during this CME on the breast cancer will translate into improved patient care and enhanced clinical practices. We thank our chairpersons, speakers, organizers, and participants for making this evening a great success. Thank you so much.